Let's begin this session for today. On the outset, I'd like to thank the Indian Society of Vascular Intervention Radiology National Leadership for giving us this platform and this stage where we can provide junior residents in radiology a platform to ask questions and learn from the best in the business. And I'd like to introduce and thank our guest speakers for today's session as well. First up, we have Dr. Shyam Kumar sir. Shyam sir is the president of the ISVIR as well as the head of the department at the Department of Radiology and Interventional Radiology at CMC Vellore. We have with us Dr. Matthew Cherian sir, who is the past president as well as the head of the department at the Department of Radiodiagnosis and Intervention Radiology at KMCH Coimbatore. We have Dr. Ajit Yadav sir, who is the secretary of ISVIR and he's a senior consultant at the Department of Interventional Radiology, Sir Gangaram Hospital, New Delhi. We have Dr. Pushpinder Singh Khera sir, who is the joint secretary of the ISVIR as well as the head of the Department of Diagnostic and Intervention Radiology at AIIMS Jodhpur. We also have with us Dr. Jenny Gandhi ma'am, who is a consultant intervention radiologist at Shalby Hospital in Surat. Lastly, I'd like to take this opportunity to thank my fellow ISVR junior wing members, Dr. Darshan Tumar from Sir Gangaram Hospital, Dr. Avinash Malla from Miyot Hospital, Chennai, Dr. Shikhar Garg from CMC Vellore, Dr. Damandeep from AIIMS Delhi, and Dr. Prajwit from Fortis Hospital, Bangalore. We have worked relentlessly towards junior wing activities and especially towards making today's session possible. This was our brainchild when we thought about this idea a few months back, and we take pride in the fact that we wanted to do something actively towards the radiology and IR community in India. So I think the best way forward is to guide young residents towards a possible career of IR in the future. So a few years back, all of us were in a similar state where we had not much material to prepare towards IR and what exams to give and who to contact. So we 5 years later down the line, the number of IR opportunities to train as an IR in India has exceeded and has grown leap and bounds. So we thought we would give this platform to all you residents so that you would make best usage of this particular 2-hour session, and it would obviously help you in the future to becoming an IR. So without further wastage of time, I'll be starting today's session. So to start off today's session, we have Dr. Shyam Kumar sir, who will be delivering the first lecture. His topic is IR, an opportunity to serve. Over to you, sir.
Thank you, Dr. Samat, for this wonderful introduction. Am I audible?
Yes, sir. Yes, sir. Audible, sir. Your screen is visible, sir.
Okay. First of all, I'm really excited to see this very unique program where you have invited many radiology trainees and to give them a hint how they can progress towards becoming an interventional radiologist. So my presentation is very short, and I'm thankful to Dr. Shikhar Garg for conducting a quick survey why someone wants to become an interventional radiologist. And if you can see this spreadsheet, several people have taken it as a passion. They want to have some variety in work. You can see that some of them wanted to solve the problems of others. And you can see that serve the needy. So my particular topic is to talk about interventional radiology. It's an opportunity to serve the needy. So before I ask you or anyone else why you want to become an interventional radiologist, I must share, it's my duty to share why I wanted to become an interventional radiologist. When I completed MBBS, all that I wanted to do was just to do one post-graduation and settle in life and enjoy life. During my internship, I heard about interventional radiology. And in fact, a close friend of mine who wanted to become a pediatrician, he was going to talk to a pediatrician and get some mentorship from him. I went an escort along with him. And as we were talking to that pediatrician, he said, do you really want to do pediatrics? Why don't you do something like a radiology and further you do interventional radiology and you will be able to serve more people. So at that time, my friend still wanted to become pediatrician. He went in a direction and he has become a very famous and very contributory pediatrician to the world. Whereas I asked this pediatrician, what is interventional radiology? He gave me an example where a patient has undergone a major surgery and patient had internal bleeding that could not be easily sorted out by even resurgery. Whereas an interventional radiologist came, he just did a half-an-hour job. He put some thin tube inside, and he put some blockage items inside, and the bleeding stopped. And the patient came out of the hospital within a couple of days. So that really excited me to hear there is something called interventional radiology. So at that time, I met a senior of mine who was doing radiology post-graduation. He showed me a book of, let us say, Reader's Digest size. He said, this entire book is on interventional radiology. So I went through that book, and it was really, really useful to me. So then I thought, let me do radiology, then learn some interventional radiology. And all that I want to do in my life was, at least I should do one embolization and save one patient's life. So I joined radiology with the intention of doing interventional radiology. And I was very fortunate at Christian Medical College, Bangalore. During PG itself, I had a lot of opportunity to involve in interventional radiology. Subsequently, when I worked at the level of SR also, I had lots of opportunity in radiology.
Now you see a nice.
Okay. Then I had opportunity to serve many patients, and I also learned the meaning of what to call as serving a patient. And subsequently, I had the opportunity to work overseas in Australia and in the UK, and I worked as a consultant radiologist, but at the same time, I could learn many more things about interventional radiology. I would like to share 2 cases with you. This is a 16-year-old boy who had significant liver problem, and he was referred to our center for liver transplantation. This was approximately 20 years ago. And as he was referred, he was worked up extensively. And this was just at the beginning of liver transplantation history in our center. And during interdepartmental meeting, we were asked, can anything be done from interventional radiology till he is ready for liver transplantation? We can see some representative ultrasound images. The liver is enlarged, and you can see multiple comma-shaped collaterals within the liver. And this is an exam spotter for all of you who are preparing for exam. So this is a case of Budd-Chiari syndrome. We took him for IVC-gram. IVC looked predominantly okay. And you can see there is some extensive indentation over the inferior vena cava. The walls of the IVC are concave, which indicates it is enlarged liver, swollen liver, which is compressing the inferior vena cava. His all hepatic veins were obliterated. They had become like fibrous cords. And you can see that one vein, which is only left from the liver, it is on the left side and it's directed downwards. And that has got a focal stenosis. This is caudate vein. We plastered this caudate vein because the caudate vein is directed caudally. We came from femoral vein and we plastered it. And he showed a good clinical response. And subsequently, we had to stent this vein. This patient was identified to be having JAK2 mutation. He has hypercoagulation, which actually resulted in this kind of Budd-Chiari syndrome. And remember, this problem, how much ever we control, this will be there for lifelong. He developed IVC narrowing, IVC plasty. Each time he was developing a new problem, we kept on treating. After all these physiological modifications, he required tips for a period of time. Since we have already placed a stent in the inferior vena cava, we have to go through the stent. We can see this balloon is narrowed in the center, which indicates that that required a plastic. And after that, we placed the stent. So this patient had several interventions. And after that, he did really well. So if you see his journey with us, he was there for more than 2 decades. And if you see on the left-hand side, he is a patient. He has got Budd-Chiari syndrome. He has got JAK2 mutation, hypercoagulation. He is on anticoagulation medicine. He has undergone nearly 15 interventions, angioplasties, stents, dips, revisit to the hospital. Whereas if you see from the other side, he's a person, initially he came to the hospital when he was an adolescent. He even thought, because he required a long-term treatment, whether to take up an engineering course nearby the hospital and continue his management. Now he has completed graduation, MBA. He's a manager in a jewelry shop. He has got a happy family. He's married and he has got a school-going child. And every time he comes, he doesn't look like a patient. He just comes for a follow-up and he will ask, "How are you, doctor?" before I ask him. And he has got a very happy family. So this is very nice to see a patient who has got a long journey. So if you look at him as a patient, we only see the condition and interventional procedure. Whereas if you see that you have served a person, you see that he's a happy man. So when we are into the treating of a patient, you focus on the patient. I don't like to call a patient of BCS a patient of subarachnoid hemorrhage. Instead of labeling patient like that, call the patient by name. I would like to show one more case. It's a 54-year-old man. He's from nearby hospital. He had few episodes of TIA over a few months. He was referred to us for a cerebral angiogram and intervention if required. Generally, we have a belief that diagnostic angiogram is gold standard. It is incorporated in our belief as well as it is mentioned in the textbooks many places. But in reality, that gold standard investigation may not be required. So when we reviewed this patient, he had some of the TIA episodes documented in our packs. And sometimes he had a small TIA, he did not even come to the hospital. And sometimes he got the treatment by alternative medicine. The fact of the matter is, there are multiple episodes of TIA, all happening in the right MCA territory and watershed area. So this is one of the documented TIA, which I'm sharing with you. You can see that all changes are seen only on one side. So we did some more study about him, and we can see that in his MRA, there are some vessels cut off on the right side. You can see M2, M3 branches are not seen in some areas. And there is a significant loop of ICA in the tonsillar area that's on the right side only. I'd like to show some more details about him. He owns a pharmacy shop. He also does a lot of social activities. Every weekend, he goes to some public schools and he takes classes for children. He gives motivational speeches. And just to mention that he's a right-handed man. And he was mentioning that there was a lot of dust near his shop. And he also told me that when I inquired more about why dust is coming to his shop, he said there is some change in the road height outside his pharmacy shop. Basically, he stands inside the shop and there is a small opening. And through the opening, he dispenses medicine and patients will be from outside the shop. So due to some repair of the road height has changed. And I would like to show this photograph. So this is the entry to his clinic or a shop, and he stands from inside. And this is how he delivers the medicine. And you can see that through this window, there is a particular height is adjusted. So what we realized is, after all this, perhaps something is happening to this segment of the ICA, which is curved in the tonsillar area, maybe having repeated minor dissection, which you are not able to see, and thromboembolism is going to the same area, which is connected to this area. So we asked him to increase the height where he was standing from inside the shop so that the level has reached to the original. And we gave him a cervical collar so that his right hand movement is less. And he was continued on antiplatelets. And after that, there are no symptoms for the last few months, whereas symptoms were coming regularly before. So we still don't know the full answer, but our hypothesis is it is a recurrent minor episodes of dissections, which is happening in the tonsillar lobe, and it is often happening only on the right side, which is excessively using. And this is the cervical collar, what he has applied, so that his neck movement is less, and he is doing very well. So I have shown you, friends, two case examples. First case example, where we have done lots of intervention and patient is doing well. Whereas second patient who was also referred for intervention, we have done a lot of work, a lot of thinking. And finally, our intervention is 0 for him, but he is doing very well. It is just to show that it is a balancing act for us. It is not that every patient we get, we grab them and do intervention. We need to identify who is the deserving patient for intervention. If not, it is instead of saying no to intervention, we have to find out to our best what could be the possible reason and play a role in the management of the patient. Finally, we are going to address the patient, not a disease per se, or we are not focused on the procedure. I have made few points for you to be beneficial. I know that most of you are having high IQ because you already got radiology seats. We need to be having good EQ, respond to emergencies when you are in interventional radiology. We need to take quick decision, see overall outcome of the patient rather than focusing particularly on the intervention alone. We need to have several other points, especially need to have a lot of patience. I would like to put a star here after telling this. I myself may not be able to maintain this, but it's a continuous learning phase. Compassion. Without compassion, whatever you do, it is not going to be meaningful. I would like to conclude this short presentation saying that interventional radiology indeed is a very exciting field. It gives a lot of scope for patient care, education, and research. Now, to see whether you also want to do intervention or not, I've got small suggestions. You approach somebody who is already practicing intervention, who is nearby, or you contact anybody through contact from ISVIR. And if you are seriously considering intervention, spend some good time as an observer in the department in case if intervention is not happening in your own department. And subsequently, you can take a decision. So these are all the points which I wanted to share. And I want to show finally a picture. This is our office. During daytime, this area is very busy. You'll see several footfalls. Whereas in the nighttime, when you're doing an intervention for a young lady for postpartum hemorrhage, you can see that the family is outside. And this particular lady, who is the grandmother of the neonate, she's playing the role of interventional radiology. What compassion we are showing inside the room, she's doing the similar attitude to the family. So these are some of the points which I wanted to share. And I would like to stop at this point and hand over to the next speakers. Thank you for your attention.
Thank you so much, sir. I think sir raised such important questions as to why our motive should be to take up intervention radiology. Especially that last image was very captivating, sir, and was a very nice corollary to what we do as intervention radiologists. Thank you very much, Shyam sir, for giving that wonderful talk. Next, we have with us Dr. Matthew Chirian, sir. Sir's talk today is titled, "Are you ready to handle the battles ahead as an intervention radiologist?" Over to you, sir.
Yeah, I'm just... Can you see my screen, by the way?
Yes, sir. Yes, sir. Your screen is visible.
PowerPoint is visible?
Yes, sir. Yes, sir. Done.
It says, "Are you ready for the battle ahead?" Is it there? Okay.
Yes, sir. Yes, sir. We can see that.
Thank you so much. Okay, so Shyam, I was just, sorry. Yes, so thank you, Shyam. I mean, that was a good introduction to why we should take up interventional radiology. And especially, I think the tagline is, if you have no compassion, please don't do it as a business because it's not worth it, right? Okay, so I just titled this topic, "Are you ready for the battles ahead?" And this is not just for interventional radiology, it's for just about everything in life. And by everything, I mean anything from your career to your marriage, everything has got its own challenges, okay? And so when we talk about battles, there are several that you have in your mind, you know. For example, a mind can be a big battleground. One is the fear of failure. The second is the fear of hard work. The third is the fear of radiation. And many people sometimes say they're scared about that, you know. When it comes to the job front, we sometimes get nervous just thinking, do you think I'll get a job or will I not get a job? Or, you know, and these itself can be fears that trouble us enormously in our careers and in our lives. Then, of course, the one that always everybody's worried is, can I retain my turf or not retain my turf? Just one second, just getting the, okay. And these also trouble us a lot. And very often, the one that worries is, will I get disliked? How do I handle my competitors? So all these can be challenges in our life. So let's just go to this mind component. The first thing you must understand that our mind can deceive us to believe a lie that we are not good enough. I'm talking about everything, any career, what you take, a new procedure you want to start in your life, or you want to subspecialize or super specialize, and you want to take up a hospital, a new job, a new environment, and your mind can deceive you to believe that a lie that you're not good enough, or sometimes can deceive you to believe that there is absolutely no problem. Even that can be dangerous. Now, the big problem in India and actually many of the Asian countries that we are very, very worried about. Just one second. I don't, I'm in a Zoom meeting. Do you want to talk now? Okay. So the thing is that, so you understand, this is a beautiful movie. If you ever get a chance, watch it. It's a movie called What Will People Say? It's a Norwegian movie about a Pakistani family who's there, and that whole girl's life is destroyed. Actually, she's the producer of the movie. It's her own biography that she writes, where the worry was, what will people say? Now, the big problem in India, so often we take a career more because of what will people say. You take up, you're worried that suppose I take up interventional radiology, I start this course, then in between I can't take it and leave this course, what will people say? Failure is looked at a very, very negative way in India, and which is not so much abroad. Very often you must understand failure is one of the best teaching experiences you can have. And the greatest tragedy in life is giving up without trying. So one of the fears about taking any super specialty can always be, what if I fail? What if I'm not good? What if I'm not a success? And what will people say? And first of all, you must get rid of this and start understanding I have to do things because I have to give this try. And if I don't give a try in life, I will always regret thinking, maybe I could have done something better in life. I want you to understand this. If you dream of IR and it keeps you awake at night, no one can stop you. See, this is what Abdul Kalam said, that your dream should keep you awake. This is what a dream is. And I can assure you that we have trained so many people, and I know one thing, each of these people, and I cannot tell so much after the DRNB came because the selection system is different. It's more about a theory exam. But when we used to do these vivas, we could see the passion they had even just to get inside. And now we find the passion that they develop at least after they start working. I want to make you understand, therefore, that nobody can stop you. If you have a dream and if you've got a passion, maybe you may not have gotten to the institute of your choice in the first year, but if you persevere, you will definitely fulfill that dream. I've seen people, when we started, we had very basic training, but we could still grow because the dream was so big and so powerful in our mind that nothing could stop us. Also remember, failure is a great teacher. Now, suppose you go into IR actually, and you find that there is a problem. You panic a lot, and this is driving you crazy. Okay, maybe after 3 months, you just felt you couldn't handle it. It's perfectly okay. You learned this big lesson in your life that this is not meant for you. And that itself is a great teacher, because in your heart, there is no regrets. This will rarely happen. But the reason I'm trying to tell you, let not your fear of failure take you away from your dream. See, one of the most beautiful examples in recent time is the life of J.K. Rowling. She was so passionate about writing. She finally didn't have a single job. She lost her marriage. She was living under, dole, that is a government accommodation that she had, desperate about publishing a story, and there was nobody willing to publish it. finally, the 30th publisher took that book home. By some freak chance, his daughter read the book and found it so fascinating that he said, okay, I'll do it. And she is sensational because nobody in this century has sold as many books as she has from a person who was living in just poverty. The thing is, she had that vision, she had a dream. And when people said you're not going to be a success, it did not change her. But finally, she succeeded. I want to make you understand that fear is one of the biggest barriers that you have towards growth, toward excelling in your life. Some people have this thing of fear of hard work. I love this statement is say, I hate that word lucky. It cheapens a lot of hard work. There is nobody who's done well in life who is just lucky. Everybody put in hard work. If I'm recognized as a well-known interventional radiologist because of years of hard work. Now, but you must understand, when I look back, was it hard work? No, it was not hard work for me, but it was a lot of hard work for people who watched me. Of course, there are sacrifices. My wife felt I didn't have too much time at home, and when I was working and trying to develop the specialty. But having said that, for others it may have looked, but I honestly enjoyed it, and I enjoyed every moment. See, Karim Walji, when he was speaking in one of the SIR's, one of those gold medal lectures that he had, when he got his gold medal, he said this beautiful statement, which is so true for all of us. He says, my mentor, Joe Brookston, said that, imagine a life of an interventional radiologist. I can't believe they pay us to do this. If your hobby and your passion are the same, and if they become your job is no longer work, and you get paid for it. Even today, somebody is saying, doctor, you work so hard. Don't you need some free time? Don't you want to play golf or take up some hobby? He said, for what? Interventional radiology is more fun than playing golf. So why should I play golf when I'm having so much fun in the hospital? I look forward to Mondays. When people put all these jokes saying, Monday blues, I say, no, it's never a blue for me. I just love doing procedures, thinking of procedures, teaching procedures, mentoring people. Everything is a matter of great joy. This is Albert Einstein's great theory of relativity. He says, when you're courting or spending time with a very beautiful girl, an hour seems like a second. But when you sit on a red hot stove, a second seems like an hour. So remember one thing, if you're really a passionate interventional radiology, it's not hard work. And it's like saying you love this girl, you walk 100 miles, for getting something for it's not hard work. And believe me, that's been my realization. IR is not hard work for me. For somebody who's a job, it's hard work. And seriously, don't take up IR if you don't think you love procedures and you love patients and you love doing good for people. What about the fear of radiation? If you follow the rules, nothing happens to you. Today, machines are safe. We got fantastic lead jackets with double layers in the front, which gives you protection. The beautiful acrylic-based lead barriers. And if you take all the precautions, you don't unnecessarily do fluoroscopy. You don't take awkward angles for more than what's necessary. You try to keep a distance, reduce the number of acquisitions. All of them put together, you'll see it doesn't do anything to you at all. You have to be safe, but the fact is, seriously, you don't have to worry. And all my radiologists who worked with me have had children, they're conceived, and none of them have brought up kids who are abnormal, or even not one of them had a child with a congenital anomaly. I'm not saying that radiation is not dangerous, but the fear is totally not necessary. And remember, we all started our careers working on machines that are pretty primitive, and everything was fine. Next thing is your fear. Can I retain my turf? It's always a fear. The neurosurgeons will take it, the vascular surgeons will take it. So the first thing, know your opponent well. The first opponent is your cardiologist. They are very trigger happy. They've got good clinical skills. But you understand, they've got very poor technique, especially when it comes to handling small vessels. Their technique for handling the peripheral and the neuro vessels can be very difficult. And often we find that we are far better. Also, they have very little understanding of imaging. They need the help of somebody to tell them, what to say, this is an aneurysm, how to measure the neck, how to measure the iliac arteries, what is the angle. So we have a very good understanding. They can never figure out where the bleeding is coming, how to target the vessel, how to understand. So we have a very strong point out there. What about the vascular surgeon? They're very aggressive, but they're very rough with vessels. They very often have poor understanding of imaging, and technical skill and understanding of hardware can be very poor, especially when it comes to embolization. Maybe to angioplasty stenting, I found them reasonably good, but the other areas they are very, very challenged. What about the neurologists? Again, good clinicians, poor understanding of imaging the way we understand imaging. They can tell a stroke, but not really go to the vessel, find how tortuous the anatomy is. Can I dissect? Can I not dissect? What should I plan? How do I plan the hardware based on the anatomy? I've never seen it happening in them. What about the neurosurgeon? They are aggressive. Again, they can be tough with vessels. Again, they don't seem to understand imaging the way we look at it in terms of how we reach. They can see there's an aneurysm, but they cannot really understand and transform it or translate it to the workflow. And technical understanding of hardware, again, I found, I'm not saying all of them are that way, but I've generally found that our understanding is far better. So we have to understand this. So what are the strengths? They're clinically sound, but remember one very important strength, the patient reaches to them first. And we have a problem out there. What is their weakness? Poor in interpreting images, poor knowledge of hardware. Technically, they may not be very great. Okay, so we know where their weakness is. We know where their strength is. So what should we do? We know that we are very, very good at interpreting images. That's why I tell you, every interventional radiologist should, first of all, be a good diagnostic radiologist. Some people say we don't need it. I believe we need it. We don't believe anybody's reports. We review everything ourselves. We sometimes take a second opinion from a good radiologist in a department, but we obviously will only get convinced when we believe that it agrees to our thinking. We are technically good. We are innovative. We think out of the box. We can find out solutions to things that are even not there in the text. Our weakness, we depend on doctor's reference. Many are poorly read. This is a challenge. They don't know the lesion literature. They don't know what's going on in the world in terms of what are the statistics, what's happening in stroke. Right now, we are talking all about large volume strokes. Where is the deficiency? Where are the plus points? Is it really practical in a country like India? We don't know it. Many people don't read up, and I am very finicky about the fact being well read, understand technology, understand literature, and so that when there is a conversation or a talk, you can be convincing. We are clinically poor. We are happy to do procedures, but we fail to do ward rounds. We don't like to do ward rounds. We just want to take referrals. We don't even know to clinically examine the patient. A radiologist who does an ultrasound in my department, we tell them, why don't you examine the patient? Your job becomes much faster, but somehow they feel, I've done radiology, I'm no longer a clinical radiologist. You have to be a clinician. You are a surgeon and a physician rolled into one if you practice interventional radiology. So what are the changes? Become a good clinician. Examine them properly. Do a detailed examination. Feel a patient, every pulse in the body, not just the femoral pulse or the dorsalis pedis. See his breakers, feel his carotids. Take your step, check for a murmur. See if there's any discrepancy. Check the blood pressures. Have a look if there's any abdominal brewing. Neurologically examine the patient if necessary. Talk to him. Run your own OPD. There is no way out. You're a surgeon. You're not a radiologist anymore. You have to have your OPD. You have to see patients. You have to interact. You have to talk. Be a good diagnostic radiologist so that you can understand images better. Be up to date and ensure people know what you do. So you have to go to the public. You have to ensure that the patients come directly to you because they know that you're a physician who treats. They should know about fibroids, about prostate, about aneurysm that you treat, about stroke, or whatever you do. Give lectures. I know multiple public meetings help them. Get into the social media. Everything. Evolve, adapt, and learn so that you're good. Now, the problem, like I said, is when you take IR, you will be disliked. Not many clinicians are going to get very, very excited unless you help them out when they are in a situation. They do a biopsy, there's a bleed, there's a PCNL, there's a bleed. They will love you for that. But when you take an aneurysm and coil it, they may not be very happy about it. So you should understand that you should have the courage to be disliked. By the way, it's a great book. Do read it if you have a problem about dislike. Look at this. This is the request that you should come in to Portland to Charles' daughter. Visualize, but do not try to fix. Did you think it mattered? Look what he says. Things have been both rewarding and at times frustrating. In the early days of angioplasty, was thick-skinned enough to stick with it, even more glad there is so much still to be done, so many others to help do it. In the end of the day, he says that, because I was thick-skinned, I survived. You will, when I started my career, people used to tell I'm doing experiments, to go and complain to my chairman that I had a complication of treating a carotid body tumor, the patient had a stroke, they brought it to the death meeting. It was such a huge mess. Who would like you? Why should they like you? You were taking complex surgeries and doing it in minimally invasive ways that was so amazingly rewarding. People were not happy about it. And this will continue to happen. And if you're scared about that, you can't survive. Because you do what's right. I always tell a beautiful example. If you're walking, you see a German Shepherd walking on the road. All the mongrels keep barking. But the German Shepherd is not bothered. He doesn't care. He doesn't bark back. He walks because he wants to. Mongrels will always bark when you do good work. When your job is mediocre and useless, nobody cares about you. But do you want to retaliate back and start barking? Then you lose focus on everything. Your focus, your goal is to become an interventional radiologist and do it well. Forget about the mongrels. They will bark. Anytime anybody does good work, they will bark. Even today, we have got problems with people who are upset with whatever we do. But who cares? Once you're secure in the fact that the quality of our work is good, you will survive. Since I took from the Bible, of course, just to tell you, if possible, so far as it depends on you, live peaceably with all. So we try to be peaceful. We try to be good. We try to help them out and bail them out in difficulty. Even if a consultant has been nasty, but next time it's a complicated, we still help them out. And we have found that people change. We have found that people finally who were very difficult became friends. So don't start with war. Try to be nice. Try to be good. Try to be kind. Try to be understanding. But at the same time, if you find it impossible, there's nothing you can do. You have to continue your work because you know what you could do is extremely good for patients. Far better than any open surgery. Beautiful statement. I'm not here to win a popularity contest. I'm here to work and have a career. If the haters hate me, I'm ready for the criticism. It's absolutely true. You have to understand if you're growing up the ladder, if you're doing well, your cheerleaders will decrease. Your father or mother is the only one who will be happy. Even your wife and kids may not be too excited about it. Believe me, it's a fact. Even they may find that, so what's there for me? Your life is so good. Okay, right. So next worry we have is, will I get a job? Of course you get a job. Today, with the number of procedures coming, stroke is an emergency, there's a shortage of people. PPH, hemoptysis, bleeding patients, you can never stop them. Maybe you lose some peripheral vascular disease. You will lose some angioplasty. But there's a whole lot of other procedures that are life-saving, that totally is so good that in my city of Coimbatore, every single hospital has a interventional radiologist, and there are 6 biplane labs in the city alone. Why? Because the whole city knows what the impact of interventional radiology that we practiced for 32 years. So remember that there is not a single good hospital today who does not want an interventional radiologist. And we have trained about 35 radiologists in IR so far. In India, we got 32 practicing, abroad 3. All across India, they are placed. And the average starting salary for these people is like 4 lakhs a month. Believe me, most of them get a job before they leave. They call us, do you have an interventional radiologist that is trained? The reason is we train well. Well-trained interventional radiologists are in demand. But if you're poorly trained, I know it can be a challenge, okay? So remember the normal law of nature. If you're not there, if something is, nature loathes an empty space, so nature will make sure that empty space is filled. So there are many, many hospitals, because of want of an interventional radiologist, somebody fills that place. Then getting back the territory is very, very difficult. That is why the more of us, the better for us, and the greater the practice. So finally, the last slide, I'm taking a Mark Twain. The secret of getting ahead is getting started. Start preparing. Go to a center, be an observer, watch what they do. The secret of getting started is breaking your complex, overwhelming tasks into small, manageable tasks and starting on the first one. Don't think of the whole picture, you'll get scared. My God, I get an interventional radiologist. Then what happens to my life? Then what happens? No, it's not that. I'm interested. Let me start. Let me talk to students who got into the program. Let me talk to them and see how they prepared. Let me talk to them and see how do they enjoy the procedures. Let me talk to people who passed out and see how this works, right? So in the end of the day, I hope I've taken you the journey. Fears is the biggest challenge you can have in life. And many of these fears are totally uncalled for, okay? So if there's any questions or anything, I don't know how it works. I'm glad to answer, or you can, mail me or talk to me or WhatsApp me or whatever. And I hope it's kind of helped you to understand that if anybody sitting here in this audience today listening to this is feeling, I'm not ready for this, and the doubts and the fears, I hope you understand there is nothing to fear. Okay, that's it.
Yes, sir. Thank you. Thank you so much, sir. We have around 220 people listening in. So I'm sure all of them have definitely enjoyed listening to your talk, sir. Every time we as IR trainees listening to your talk is always an honor. Thank you, sir, again for an amazing talk. We'll have a question and answer session towards the end of the talk again, sir. So moving on, we have next Dr. Ajit Yadav, sir, from Sir Gangaram Hospital in New Delhi. Sir will be talking about why to become an interventional radiologist. Over to you, Ajit, sir.
Yes. Hi, Samath, can you hear me now?
Yes, sir, I can hear you, sir. Screen is visible, sir. It's sharing.
Yes. Okay. Thank you. So, good afternoon, everyone. Myself, Dr. Ajit Yadav, and I am the Secretary of the Secretary of the ISVIR, and I'm consultant at Sir Gangaram Hospital, New Delhi. I'm going to show you the one famous clip, and you're going to watch it like. So this is not about how people think about us. This is like this is a comedy show, and they were showing that how radiologists are working and something. But this is the common mentality of the people who is living in the society. The how the radiologist is doing work in the hospital. Even our colleagues think of us as a non-clinical people who just doing a corporate job from 9 to 5. But that scenario is now changing because that we have many branches that is actually treating the patients. So one of these branches is the interventional radiology. Whenever any of you, after the radiology, you went for a super specialty exam. We don't have so many options in the super specialty, but still we have some of the fellowships and degree, maybe DRNB or DM. So some of the factors that affect while you're choosing the super specialty, that is the clinical versus non-clinical work, about the salary, recognition amongst the common people, recognition your colleagues, chance of becoming in the field, because everyone wants name and fame whenever he's come into the field of the, whether it's musculoskeletal or it's a interventional radiology or whether it's a fetal medicine or any other branch of like general radiology. Risk involved and the occupational hazards. The most common thing, as Dr. Matthew already described about the chances of the radiation and the women's, because the females, they are more worried about the radiation, how it's going to affect the reproductive life and how it's going to affect the kids. And so there are so many things in your mind. Come to the clinical and non-clinical one. So I'm going to my story. So I did my primary schooling from a small village in Mahendragarh, Haryana. And I did my 10th from that Narnaul, Haryana, and 12th from the Sonipat, a hostel, a residential school. Then after 1 year drop, I got selected for AFMC All India and Rohtak, but I chose my undergraduation from MBBS from the TGIMS Rohtak, and I completed my MBBS 2006. Then I want to be a surgeon. I did everything for that, got that rank also, but at the same time, I got the rank 1 at the Sir Gangaram Hospital. For that, I was offered DNB Radiology. Now confusion starts. So at that time, when we got a rank, then it's very difficult to carefully choose a medical specialty. If you didn't get a rank, you always have a chance to pick up whatever you like, maybe surgery, medicine, ortho or something. But whenever you get a rank, then it's become the peer pressure, because the toppers always choose radio diagnosis, dermatology, general medicine, and something like that. And the surgery was on like very low, on the lower side of the ranking. So it's always the peer pressure. Do we have an option to choose even if we are topper? No. Because of the peer pressure, because of the something at that time, maybe we are focused enough for something, but they're not much focused enough as become whenever we are topper. So at that time, I can bet you most of the radiology students, they have choose the radiology because they are at the top rank, not because the radiology is their first choice. So finally, I choose the radiology over the surgery because of so many factors. I can't tell you because my girlfriend was in Lady Harding, so I want to shift to Delhi. I don't want to go to Rohtak. So there were so many factors, so that I have to shift to Delhi, and the radiology is the preferred choice because at that time surgery was not there in Gangaram. But happiness was short term because I start doing the radiology and I found it's not suitable for me. So I was in mood to drop again for the PG after 2 months or 3 months. But then I found my mentor and my IR teacher, Dr. Arun Gupta at Sir Gangaram Hospital. And I found that he is doing something related with the blood and doing some puncture, and there was some blood coming out. And so that was the moment I go to Dr. Arun Gupta. I said, I want to do this thing because I don't want to do ultrasound and CT scan just in front of the screen. And so can I work with you? And he said, okay. At that time, he gave me the thesis on the PTBD. And during my DNB radiology, I did some of the intervention procedure, not the like bigger procedure, but some of the hands-on procedure. I completed my DNB radiology in 2011. So what's next? Before my DNB radio, now this time I have decided that I will go for an IR. I will not go for a diagnostic radiology, not going for the fetal medicine or other thing. So this time, because I was mature enough, no confusion in my mind at all. At the time of choosing the specialty after MBBS, I was confused. But after radiology, I was sure that I have to go for an IR. So if you want to be an IR, this is the time you have to decide if you want a clinical branch or if you want to do something that is related with the minimal invasive treatment or something related with the patient. And if you have interest or if you don't have interest, you can come to my institute, you come to Dr. Matthews, Dr. Sham, you can shadow us for a day and you are going to realize that whether you this branch or not. So that was my story, how become an IR and how I reached this stage. After that, I am reached this stage after the 15 years. And I am very happy with this, with my decision at that time that I want to become an IR. Now come back to the factors that affect a life whenever you decide to become a diagnostic radiologist versus the IR. So if we have a data from the internet, the radiologist salary that comes around 2 lakhs per month, where the interventional radiologist, this is the initial salary we are talking about, that is 3 to 4 lakhs. And Dr. Matthew said, all the students that came out from the KMCH, they are earning more than 4 lakh rupees in a month. So the initial salary versus the salary at the 10 year, if I'm saying the experience after 10 year as a radiologist or interventional radiologist, is approximately the same ratio is there. So if you are initially earning 2 lakhs as a radiologist, definitely the intervention radiologist is going to earn 3 to 4 lakhs. And after 10 years is going to increase the threefold increase in the diagnostic radiology versus the 4-5-fold increase in the intervention radiology. Recognition among the common people. So as a diagnostic radiology, we are not in the front of the people. We are not seeing to the society. So we are only behind the computer or behind the curtain. We are doing almost all the thing for these for the patient, but the patient only got our name and the signature on the report, radiology report, and that always they ask, मेरी रिपोर्ट थोड़ा जल्दी दो, मेरे डॉक्टर अभी वेट कर रहे हैं, आप मेरी रिपोर्ट जल्दी नहीं दे रहे, मेरे डॉक्टर ओपीडी में बैठे हैं, मुझे रिपोर्ट अभी बना के दीजिए, आप काफी टाइम लगा रहे हैं. सो इट्स ऑलवेज अबाउट द रिपोर्ट, इट्स नॉट अबाउट हु इज डूइंग द रिपोर्ट and who is sitting on that desk. Versus intervention radiology, the people are sitting in our OPD, they were waiting for us and they were asking कि procedure के लिए. So difference is आपको डायग्नोस्टिक रेडियोलॉजी में कोई नहीं जानता वर्सेस इंटरवेंशन रेडियोलॉजी में, because you are doing all the OPDs, all the ward, all procedures. So patient आपसे मिलने आएगा. So that is like a clinical work. Recognition and colleagues. If a diagnostic radiologists are very famous in the clinicians. Why? Because वो उनके लिए diagnosis बना के देते हैं. But intervention radiologists become more famous in the peer colleagues because you handle their complications. Whatsoever complication they do in their surgeries, we are always there to help them out. So making a diagnosis versus helping them out or bail them out from their complication, this is the difference between the diagnostic and intervention radiology. So both are famous in colleagues, but intervention radiologist plays a bigger role because you bail them out after they do something or something problematic thing, or they want to do some, they admitted some patient like a liver abscess by the gastroenterologist, and gastroenterologist make कि ने बोला कि diagnosis, make a diagnosis, ultrasound वाले ने बना दिया diagnosis, there is a liver abscess, but the intervention radiologist can drain that abscess within 5 minutes, and that is the beauty of the intervention radiology. We can do the procedures that actually previously took a lot of time. So non-surgical treatment, जिनके लिए पहले gastroenterologist को surgeon से बात करनी पड़ती थी या किसी और से, or any other complication like after cholecystectomy, if there is a collection or something, it's very easy to diagnose by the ultrasound. But to bail that out surgeon, we need drainage of that particular collection. तो उसके लिए recognition जो colleague को मिलता है, जो intervention radiologist को मिलता है, that is much more as compared to the diagnostic radiologist. So chance of become famous in your field. So there are a lot of diagnostic radiologists. It's very difficult for you to become stand out in the crowd because every year there are like now, I think more than 500 or 1000 seats of the diagnostic radiologist. But in IR, we still have less than 100 seats. So the chances of become you famous in the field of IR is very high compared to diagnostic radiology. You can see the most of the IRs are in their ages, so in the 40s and 50s, except some of our pioneers, Dr. Matthew and Dr. Sham, because they are the pioneers in the field of interventional radiology. And there were few people, everyone knows Dr. Matthew Cherry and Dr. Vimal Someshwar, Dr. Sham. So because they were the pioneers of the interventional radiology, and everyone that start the interventional radiology in the 90s and 2000, every radiologist even knows them, every clinician knows them. Why? Because they were the first in their field. Still, the interventional radiology is not full of the like people, 1000 people are coming. It's only till date, we only have 1000 or 1100 interventional radiology in India. So still you have more chance to become famous, you have name and fame in the field of interventional radiology as compared to the other branches like diagnostic radiology or the less clinical branch, less famous branch like fetal medicine or musculoskeletal radiology or GI radiology or neuroradiology. Now come to the risk involved and the occupational hazard. So that is the one of the thing that you can think of, that there are some chances that there is a radiation dose from the DSA machine, or whenever there is a radiation whenever we're doing the long procedures. But you have to think about that. If you take all the precautions, the risk involved is very less as compared to the by the name, by the salary, by your choice, and by your passion. If you have a passion to become an IR, then I don't think that the radiation is causing any problem for that. So, but still, if you have any like doubt about the radiation, you can read about it, how to prevent the radiation, how to reduce the radiation dose to a professional. You should wear all the like gadgets like lead apron, thyroid apron, and nowadays we have the machines that are actually releasing very less radiation as compared to the previously the older machines. So the chance of radiation is less. And for the girls especially, we have Dr. Jenny. She is taking a lecture on women in IR, and she is going to cover beautifully that uh, that's how the radiation is going to affect the fertility in the reproduction and the chances of become some congenital anomaly or something. But that is actually not there. This is more of a myth, and that is created by our radiology only. But till date, I can say I don't have my TLD batch that crossed the limit of the radiation. Some of the needle stick injuries and other occupational hazard, that is similar to the surgeon, even less than surgeon, because we are not doing so much of the surgeries, and it's only our work is limited to the non-surgical treatment. So the needle stick injuries and other occupational hazards is very less as compared to the work of the surgery. So to conclude, if you really want to do something, you will find a way. If you don't want, you will find an excuse. So you can connect me later on also on my social media handle. These are my social media handle. If you want to be an IR, you can shadow me in my department anytime. You can just mail me, and you can come to my department, shadow me or my fellows for a day or two, or you can come for observership for a week, or you can go into any of the like nearby IR center. Every IR is helpful for the radiologist. We always tell, if you are a radiologist, we can teach you whatever you want. But if you are not a radiologist, we are not going to teach you. So if you are radiologist or radiology student, you can come to any of the IR center, and definitely you can live like a day or two as a fellow in the department, and then you are going to realize is the IR is a branch for you or not.
Thank you so much, Ajit sir. I think for everyone listening, the points that you've put in your presentation are the real world questions and problems that everyone will have before taking up this branch. You've been very real in explaining to us all these ground realities of choosing between radiology and intervention radiology. Thank you so much, sir, again for that wonderful talk. Next, we'll be having another lecture by Dr. Pushpinder Singh Khera, sir. Sir will be talking to us about the current opportunities for IR training in India. So he'll be telling us about all the current residency programs and the exam patterns that are existing in India currently. So over to you, Pushpinder, sir. Thank you.
Thank you, Samath. Am I audible?
Yes, sir. Audible, sir. PPT is visible, sir.
Right. So thanks to the ISVIR Yuva team and overall ISVIR for taking this initiative to enlighten the future IR practitioners about the training opportunities in India. So I'll just take a minute to say that Indian population, India is a huge country. It's actually a subcontinent. There's a reason why we call it the Indian subcontinent. And many states of India actually have a population equal to or sometimes more than many of the countries in Europe, even Latin America. So when we talk about the vacuum, there's a vacuum overall of trained IR professionals in India. And the window is going to be there for at least a decade or so. So we have to utilize it and train as many IRs as possible in India to take on the challenge of providing the IR services, because with expansion of economy, the improvement of healthcare, we have now requirement of IRs even in the tier 2, tier 3 cities. So the Indian scenario, if we can say, the ISVIR, which is a parent body for interventional radiologists in India, it was established in Thiruvananthapuram on 9th November 1997. And these are the current centers where structured IR training program is available. And having seen the training programs expand during the last decade, I can say that this number has grown tremendously. And now there's hardly a state in India where we don't have a training program available. So what are the courses on offer for young radiologists who want to specialize in IR? We have the DM cardiovascular radiology and endovascular intervention. It's present in 2 institutes, AIMS Delhi Cardiac Radiology and Sri Chitra. We have DM in neuroimaging and interventional neuroradiology, and we have DM in interventional radiology. Then we also have DRNP interventional radiology course, which is run under the aegis of National Board. And we have fellowship in multiple hospitals, private hospitals in India, in vascular as well as neurovascular interventional radiology. There are about 70 seats in these fellowships. And in fact, that's how the training started in India. They started as fellowships. And many of them have now gone to DRNP. And the same thing for medical colleges. We have the postdoctoral certificate courses or the postdoctoral fellowships. There's also a fellow of National Board in Neuro Intervention, which has just started, and there's just about 5 centers in this. So it becomes very confusing for a prospective IR student as to what to pursue. So I'll just take you through as to how many centers we have. We have for fellowships 41 centers all over India, which train about 2 per center, so that the number comes to 67. These are the fellows, and 35 centers offer either a DM course or a DRNP course, which is again a 3-year course. So this number is 65. So average is about 2, again 2 per center. And out of all these centers, there are 5 centers which offer only neuro interventions, 2 only cardiac and vascular interventions. A large bulk of these, they offer either combined or neuro as well as non-neuro IR spectrum. So coming to the INICT, the Institute of National Importance Common Entrance Test. Now, these institutes comprise of the various AIMS, AIMS Delhi as well as the other AIMS, PGI Chandigarh, Sri Chitra, NIMHAS, and we have total of 11 DM neuroradiology and neurointervention seats. The seats for cardiovascular radiology and endovascular interventions is 6, and for interventional radiology, the total number is again 6. And these are the institutes which again offer DM seats. Total number is 20.
Experience and experience of just understanding the atmosphere.
So these are the institutes apart from the Institute of National Importance, which again offer DM in interventional radiology, and the total number is 28. So if you add this 28 to the 23, the total number, if we go here, the total number here is 23. So 28 plus 23, it's come to about 51 DM seats. So that's a very good number. And these are the institutes which offer DM in interventional radiology, and the exam for the same is through the NEET super specialty exam. And I'll tell you when the dates for this exam are announced. Then we have the DRNB super specialty. Again, government institutes as well as private institutes. Again, it's a 3-year course, very well structured with formative assessment at regular levels and very good unbiased external evaluation at end of the course. There's a total of 14 seats per year in DRNB super specialty. And now coming to the fellowships, the total number is 67, and these are the various institutes, both private as well as the government institutes, which offer the fellowships. Mostly they are 1-year courses, and at few places they are 2-year courses. One difference that you see from the previous DRNB or DM intervention courses, that at many centers the admission is based only on interview. At other places it is an exam, and in addition to that, an interview. So these are the institutes which offer 1-year or sometimes 2-year fellowships in interventional radiology. So the national level institutes have exams only, either alone or with a the exam at most places, it involves both questions from diagnostic and interventional radiology. Very basics of interventional radiology questions are asked, not the exam pattern is such that the applicant should be conversant with diagnostic radiology, and basics of interventional radiology is asked, mostly related to case selection and whether to do a procedure or not. Not high-end interventional radiology questions are asked. And we have an exam for the NEET super specialty, as I said, the INICT, the FNB neurovascular interventions, again a very small number, and of course the institutional examinations for fellowships. Now, what is asked in an interview? Mostly we are looking at why the person wants to get into IR, because as has been said by the previous speakers, if you don't love being in IR, you will probably not be able to devote enough time and enough effort to do justice to it. And especially if you're talking of a 3-year course or even a 2-year fellowship or even a 1-year fellowship, because it's a totally different branch. So we always ask as to why you pursue IR. So you should be very clear in mind as to why you really want to pursue IR. Previous IR experience, and by that I don't mean hands-on, I mean somebody knowing what is a safe vascular access, what are the indications in which IR is helpful, what are the life-threatening indications, life-saving indications in which IR can help, whether previous fellowship has been done, but usually that is not a very important point. A word of reference for the person with whom you have been associated, either in observership or during residency, always helps, just to make sure that we are having a person who is dedicated towards the patient, nothing more. And as I said, passion towards IR and willingness to work like a busy clinical branch. So the NEET super specialty exams, total DM seats were 28. The timeline is that the online application starts sometime from July to August, and the exam is held in September, October, with joining usually done by November. And it's a computer-based exam, and it has 13 specialties. Radiology IR is one of them. And the usual pattern based on the feedback I get from students is that it's about 70-75% of diagnostic radiology questions, 25 to 30% of IR based questions. And you should be preparing both. In fact, you should be laying good emphasis on DR or diagnostic radiology, and good books that you can follow for preparation for diagnostic are the ones which are followed for FRCR. So the standard is also almost the same. Again, it's a 4 marks plus and 1 mark negative marking with 0 mark for unadapted question. And for the INICT, the institutes have a seat matrix that varies from session to session. Like in this time, we are not having intake in AIMS Jodhpur, but it will be there in January. The intake is twice a year. So the applications are invited in March for the June-July session, and October for the December session. It actually starts in January. and exam is held in April or November for the 2 sessions respectively. And the academic courses, they usually start from 1st to 15th July or 1st to 15th January. And these exams, they have 80 questions with 1/3 negative marking. And now we have a qualifying criteria. Our DM resident, Dr. Arman, will be elaborating this further, but we have something known as a qualifying criteria, that the people who qualify for the interview should have scored at least 50% of 80. So that's total possible marks. Now, the number of people who are called for departmental assessment or interview, which comprises, accounts for 20 marks, is approximately 3 times the total number of seats. And the exam is done on the same day at the same time for all the branches. So that is one disadvantage, if I may say, that the same day, at the same time, the exam for DM Interventional Radiology will be there. At the same time, there will be exam for cardiovascular imaging and interventions, and also for neuro radiology and interventions. So you have to choose as to which exam you have to sit for. And as I said, you have in this, the students generally say that more of interventional radiology is asked, but I would say it is not more than 50%. So prepare your diagnostic radiology very well. And they can be image-based questions also. So that was it as far as the taking you through the exam pattern and the opportunities available in India were concerned. And I'm thankful to Dr. Samath and my other students who gave me the inputs for preparing this presentation. And this information is based on basically the candidates who have appeared for the various exams during the past 2-3 years. Over to you, Samath.
Thank you so much, sir. I'm sure we have around still 200 participants listening to us, and I think all of them have made notes as to how to apply to these exams, what are the website links, and what are the available seats currently in India are. Thank you so much, sir, for elaborately talking about this topic. Next, I'd like to introduce our next speaker, Dr. Jenny Gandhi, ma'am. First off, I'd like to thank ma'am for accepting our invite at the very last moment and agreeing to give a lecture. This is because we had a feedback form that we had submitted to all the residents who had registered for the talk. And we had an overwhelming number of female radiology residents who had asked multiple doubts regarding women in IR and what to expect in the future. So when we discussed the same with ma'am has graciously accepted to talk on the topic. And we're very humbled, ma'am, to have you speak in front of us today. Over to you, ma'am, if you can hear me.
Yeah. Am I audible?
Yes, ma'am, you're audible.
Yeah. First of all, I would like to thank ISVIR for giving me this opportunity to address a talk regarding women in IR. As per my knowledge, there is so many confusion and myths still in 2024. In many of the female fellows or residents, whether to choose intervention radiology or not as a mainstream career after diagnostic radiology. So I will, in my this presentation, I will try to address each of them, and I will try to justify this opportunity. So just one second. Okay. So the harsh reality is today, as per a study published in Lancet 2021, women represent 71% of global healthcare workforce. And though both men and women progress similarly in this early field of their career, women are 5 times more likely to face disruption in their pathways. According to the history, where do women disappear? In 2013-14, American Heart Association.
If I may interrupt, ma'am, do you have a screen sharing option? Is there a PPT that's running?
Yeah, PPT is there. I have shared my.
We can't see it.
Okay, just one second. Computer screen, open system setting.
You can see your face, Jenny.
Okay. Just they are asking me to leave meeting and log.
We'll just wait for 2 minutes so that ma'am can log in and share her screen.
So till then, Samarth, how many actually students are there in
Yes,
this
sir.
meeting now?
So we maximum we reached was 225 students. Currently, still 195 to 200 students are online, sir.
So there are so many like interested radiologists who want to win IR, eh? And how many
Absolutely, sir.
questions do we get in the
So
Google
initially,
form?
we had a registration of more than 450 radiology residents,
Hmm.
and we have questions of more than 150. So we had to sit and narrow down the questions. We had some common questions. So we have narrowed it down to 20 questions, which we felt were apt and based on a lot of similarity. So we'll be taking the question and answer session after the students finish their presentation, sir.
Okay, and the one question is asking by, I think, one
Yes,
to
sir. Probably we
everyone.
have two
Will this
questions
be
in the chat box, sir.
will this recording be shared?
Yes, sir. Yes, sir. We're recording this and it will be shared, sir. So, in the meantime, we can probably answer two questions that people have asked in the chat box. One of them says, is the fear of artificial intelligence pushing budding radiologists into IR? And is that the reason? And if so, can we practice diagnostic radiology without need of IR in the future without artificial intelligence? That's a very apt question, I feel, sir. If anyone can answer that question, sir.
Dr. Matthew is the perfect person to answer this.
I'll answer that question, Now, the thing is that there is no way you can avoid AI. I mean, that's absolutely uh, mm, pretty stupid thinking. So AI is going to come. Now, AI can be used as a friend or a foe depending on how you utilize it. Okay. Now, so technically, it's important one thing you understand that AI can't do procedures. So it is good for everybody to do some amount of procedures. So one of the cultures that I see among diagnostic radiologists now of not even doing a biopsy, not putting a drain, that is a problem. I honestly feel certain amount of basic intervention should be done by everybody to survive. The second thing, if you're talking about diagnostic radiologists, you have to become a clinical radiologist. You should partner with the surgeon in discussions. You should partner with them in planning how therapy will happen. You're going to talk to them. For example, in our own hospital, let's say the breast radiologist, they actually go in great detail with the surgeons on planning surgery. They put the markers for them. They put the wire localizers for them. The fetal people do their own interventions. So the GI people do their biopsies. They get involved to RF procedures. So one of the things to understand, I think, to be a pure diagnostic radiologist doing nothing with a needle can be dangerous, right? So Jenny has come back. So let me give it back to her, not take her time. So basically, I'm saying every diagnostic radiologist should be able to do some interventions which will supplement his work. Without that, you will find that you may slowly get pushed out, and you should be a very, very good clinical radiologist. That means you understand the surgery, the techniques, what they do. That's why subspecialization is going to be very important in the AI era.
True, sir. True, sir. Thank you so much, sir, for that explanation. Ma'am, your screen is currently visible. If we can go ahead with the talk then, if you're ready.
Am I audible?
Yes, ma'am, you're audible.
Yeah, and my screen is visible, right?
Yes, ma'am, it's visible.
Yeah. So I'm Dr. Jenny Gandhi. I'm consultant intervention radiologist in Shelby Hospital, Surat. Surat is a city in Gujarat. So as per study published in Lancet 2021, women represent 71% of global healthcare workforce. And though both men and women progresses similarly in their field in their early careers, women are 5 times more likely to face disruption in their subsequent pathways. So where do the women disappear? In 2013-14, American Heart Association reported that 46% of residents were female, but this number drops rapidly as they progress up in their academic hierarchy. Only 38% of the faculty, 21% of the professors, and 16% of the deans are female. This gender inequality is there in every branch of medicine, so also in intervention radiology. So when you are outnumbered, you feel undervalued too. So what's the scenario of IR in India? intervention radiology is a male-dominated branch till now, and it's going to be. Currently, there are approximate 1,144 approximate IRs practicing in India. Out of them, only 40 or 50 are female IR. So the percentage of female IR in India is approximate 3.4%. I would like to skip this one. Today, the intervention is much developed, recognized, and polished super specialty of radiology, and we don't experience any, a major, physical or other type of harassment. But still, at the core of it, there are some unsaid and unaccepted bias and myths for female IR. There are overt and subtle actions and assumptions about female that affect the opportunity for professional development, recruitment, leadership, and mentoring. Female IR may face hardship from securing position as a fellow in good institute, to get an equal opportunity of learning, or to get recruited as a consultant IR in a leadership role. There are so many myths, and it is considered that female are not suitable in intervention radiology. There are many questions about their physical stamina and mental capability, whether we are able to work 24/7 wearing a lead apron, whether we are able to handle major complex cases which can take 6 to 7 hours of to complete. There are concerns also about the radiation exposure in intervention. So like after finishing a fellowship, whether any female will continue the IR as a mainstream career subsequently. So many of the diagnostic radiology fellow are either discouraged or demotivated, or they accept due to the myths and bias that the intervention radiology is not suitable for female, and they have made their mind that subspecialty of radiology like breast imaging or any other diagnostic modality like a musculoskeletal imaging, diagnostic neuroradiology, or oncoimaging is more suitable for the female radiology resident over intervention radiology. So of course, there are odds against you. There are gender inequality. There are discriminations in salary structures, of course, at the beginning, and you need to prove yourself over a period of time that you are equally capable like your any other male IR in the city or in the town or in the same hospital. Supportive environment from staff. Sometimes if you are working in the cath lab, you are considered as a nursing staff. If some senior professor who doesn't know you and who has come to the cath lab for the first time, and they may consider you as a nursing staff instead of a doctor. So choosing IR as your specialty, what's the individual responsibility and what should be the aptitude? First of all, know yourself and decide whether you are really interested in IR or not. It's just not about the handling patients, that you are not a diagnostic radiologist, you are going to handle patient clinically, whether you like it or not, whether you have a passion for it or not. Second, whether you are really interested in IR. It's not just because of name, fame, and money. If you are not sure, like Ajit sir said, have a short exposure of intervention radiology before getting into the actual fellowship or residency. Once you are sure that you want to pursue an IR as a career, try your best to get into an appropriate course. Proper training is a foundation of a successful career. If you are not trained properly, if you don't have the basics of intervention radiology, you cannot have a successful practice and career subsequently. Responsibility as a mentor department or as a society, ISVIR society. I mean, it's my humble request to everyone. There should be a structured IR course where selection criteria should be based on written as objective exams along with an interview. There should not be any bias at any point of selection process, and there should not be any injustice to any female fellow just because she's a female, and she should not be given preference over a male candidate. If she matches the criteria of training program, please provide them an equal opportunity to learn. I don't know whether this is true or not, but there should be some age relaxation for the female. Knowing what you want is the first step towards getting it, and find the appropriate teacher, professor, and mentor is a way to look forward. Optimize yourself, your behavior in an IR department. If you want equality, from other hand, you should consider yourself equally also. You should not demand any special treatment in the department just because you are a female candidate. Work equally hard. Do not take unnecessary leave or ask for any relaxation just because you are a female candidate. And on the counterpart, treat all residents equally, be it male or female. As a consultant in your practice, do not give any excuse. Just work hard and let your work speak. Make yourself available 24/7, 365 days. Whenever IR is an emergency, elective as well as emergency branch. So if you are dedicated to do IR practice, you have to make yourself available all the time throughout the day as well as at night whenever there is an emergency case, and there should not be any excuse in that. Today it's a world of digital marketing, and I think just hardworking, intelligent, and quality of work is not enough to get successful. You need to market yourself. You need to advertise yourself. That's equally important. For ISVIR, you can make us run, give us more visibility and opportunity. I mean, for many female, it is they always have a doubt in their mind whether they're able, if they pursue IR as a career, whether they're able to have a good work-life balance or not. I would say that I mean, a good family is a foundation of good career. If you are peaceful at home, you are able to focus more at work, and you are able to justice your patient, and you are able to deliver a good results. Though there should be good work-life balance. Everyone in this meet will agree that throughout the year, you are not going to have a patient at same pace. At some point, you have so many patients, you are extremely busy. Like one day you have 7 cases, other day you have 2 cases. And sometimes someday you don't have a 0 case in the cath lab. Especially a festive season, summer season, where the people go for outings and vacations. So when you have a time, you have less cases. Try to spend more time with your family and children. And when you are more busy, try to compensate it equally. So there should be, I mean, it's a individual way of adjusting how to have a good work-life balance. But if someone wants, be it male or female, one can definitely have a good work-life balance in spite of very busy, very successful. It's not hard to have a good work-life balance. So this is just a small video. My kid is 4-year-old, and I mean, I try whenever I'm busy. I mean, I go middle of the night also for stroke cases or any bleeders. But whenever I get time, I spend time with my friend, with my family and my daughter. And my family. Been through a lot of pain. Some things are not the same. So I would say that you need a good family backup and good support from your spouse. If you want to have a good career in intervention, especially because it's not 9 to 5 job. Sometimes you leave early in the morning at 6 o'clock due to long cases throughout the day. Especially when there is a neuro cases, and sometimes you go in the middle of the night also. You have come back home early at 4 o'clock in the evening, and then you leave at 10 o'clock at night because you have a stroke patient. So you need good support and backup system at home also. And it is equally important to have an understanding and supportive spouse and the family. Women are multitasking, and it's a matter of pride. We all should appreciate it. Pregnancy. So, I mean, this is maybe one of the most important point to discuss among many female fellows who wants to pursue IR as a career. So there are myths that there is a lot of radiation in intervention. Let me say just my story. I had worked in cath lab. I have done all major neuroperipheral cases throughout my 9 months of pregnancy. My mentor, Matthew sir and Pankaj sir, was very much afraid that whether I'm doing right or not. But I mean, I had discussed with my husband, and he was okay. He was knowing me. I mean, since 10 years, he knows me, and he was that even if I say no, she won't be happy and sitting at home and not doing intervention. So he allowed me, and he said that we'll see what will happen. And but with appropriate precautions like thyroid shield, good laid apron, I had worked throughout 9 months. In fact, one day, I completed my last case just one day before my date of delivery, and next day morning I had LSCS. And I returned work. I came back to work just in 2 to 3 weeks. Maybe a 23rd day, I got a call from hospital that there is one patient and who want to consult it. And it was a COVID time, like first wave of COVID. So my family allowed me, in spite of COVID and all the odds, that if you want to go, just take your decision. If you want to go, we will look after. So I mean, pregnancy, maternity leave. But if someone wants to take a break, first of all, there is not too much radiation which can harm your baby in the womb. If you take appropriate precautions, if you have a good IR practice, I mean safe IR practice rather, take a thyroid shield, good apron, take a lead glass. Whatever radiation we get, it's all a scattered radiation and not the direct radiation. And that scattered radiation dose is much less than the dose which can affect pregnancy or the developing baby in the womb. So I don't think it is risky to practice intervention during the pregnancy, but yes, individual can take a call. And if you have a group practice or there are other consultants, and if you want to take a leave, one can of course take a leave, and you can compensate it in later years of your practice. When the other consultant want a break or leave, you can compensate it their help. Same with the maternity leave and lactation. I think I don't have taken any break for maternity leave, lactation, or during pregnancy. But I mean, if you have a good support in the hospital, then of course one can develop practice and take a leave. During lactation period of first 6 months especially, my hospital management was very accommodative and appreciative that I came back so early in just 3 weeks. So they had allowed me, there was some relaxation in time, in a way that suppose I have a case and OPD, so I'm free in 6 hours, then they allowed me to go back to home and come back in 1 hour. So I mean, and I go back again, come back, go back. So it was like whenever I have a case, OPD patients, I go back, I stay in the hospital, but I don't sit just in the OPD when there is no patient or no work. And so I could cover my lactation period also without taking any leave from the work. I mean, I would like to thank Matthew sir and the entire KMCH department, because I feel that because I am trained so well that I'm able to handle all the IR cases from top to, I mean, from head to toe. And even today, whenever there is some difficult case, and if we put a message to sir, he's always there in a couple of minutes to, I mean, guide us how to plan a case and how to do it. In fact, sir takes a track also that how the case went and how is the result. So I mean, it's a very, I mean, we all fellows find very lucky to have such a good teacher and department who is backing us. Same with the Sanjeeva sir, like when it comes of motivation, he's always there, be it ISVIR or SIR or any other thing, he's always there to guide us. Like I have, I mean, no words for my family. They're so supportive, and it's true for every female who are successful. I mean, I would say that, I mean, behind every successful female, there is a family and a good supportive husband. Most important, like where I practice, my referring doctors never had any bias or any doubt in me that whether I'm able to justice the case or not. In fact, many of the super specialists, leading senior super specialists of my town, who prefer to refer me the cases just because I deliver a good results. So I mean, that is also equally important, that in your practicing city, you should not be you should not be considered, there should not be any gender bias in that also. So success for me is a success of my teachers, mentors, and my family. It's never easy, but never complain. If you work hard and let your work speak, everyone has some I mean, everyone faces in this group from a very junior to senior. Everyone faces some hardships in the initial careers, but if you work hard, persistent, and if you deliver good results, no one can stop you from a success. So thank you so much. I hope.
Thank you so much, ma'am. That was such a amazing talk. It covered all the aspects. I'm sure all female residents who had any smallest of the doubts regarding pursuing a career in intervention radiology would have greatly benefited from that amazing presentation. Thank you so much, ma'am, again for accepting our invitation at the last moment and coming online to give us this talk. So I think a big thank you to all the faculty who've been patiently with us for the past 1.5 hours giving these amazing lectures. And I hope this has answered doubts for everyone attending today. So we'll move on to the next second part of the today's session, where we have previous year toppers. We have around 7 to 8 such candidates who are doing various who are pursuing their careers in IR residency currently, and they have just begun their journey, and they have a lot of knowledge to share with all of you regarding their centers, examination preparation strategies, study materials they used, and what to expect as an IR resident. So first off, we have Dr. Damandeep Singh, who's currently pursuing his DM in cardiovascular radiology and endovascular interventions in New Delhi. I think Dr. Daman is currently attending a conference in Boston. So thank you, Daman, for making this presentation in such a short notice. And I'm hoping all the students who are listening will benefit from your experience. Over to you, Daman.
Thank you so much, Samad. Very good afternoon to respected ISVIR leadership. I hope I am audible and my presentation visible.
Yes, Daman.
So, first of all, I would like to thank to ISVIR to provide me this opportunity and platform, and also to my colleagues of ISVIR Junior Wing who have worked hard day and night to make this event possible. I will be speaking on the topic of INISS DM cardiovascular radiology and endovascular intervention, wherein I am also working as a final year DM senior resident. So, as Pushpinder sir already covered great aspect of the examination and the selection criteria, I will briefly touch upon that it is a 3-year course and which is available at AIIMS New Delhi and also at Sri Chitra Institute. So the exam is a total of 90 minutes with 80 questions. So total number of marks is 80, and for qualifying you need at least 50%. So the talking about the topics, around 50% topics will come from the general radiology, which will include your diagnostics as well as the X-rays particularly in this exam, and 50% will be IR oriented. Also, for the AIIMS New Delhi, after qualifying for the stage 1, you will have to appear for a 20 marks interview, which is usually done virtually and often done in person as well. So I will briefly touch upon the basic topics which you should prepare for theory and viva if you are considering for a DM in cardiovascular radiology and endovascular interventions. You should be confident in IR pharmacology, IR hardware, embolic agents, and vascular anatomy pertaining to the head and neck and the lower limbs. You should be confident in acute aortic syndromes, the diagnosis as well as management, and you should read in depth about the peripheral artery diseases. All the recent classifications you should be aware. Since we do a lot of venous insufficiency cases, so you should be aware of the diagnostic, clinical, as well as the treatment guidelines for venous insufficiency. You should be aware about renal intervention and also vascular malformations. So all the classification systems and the intervention. So these are the important topics which will be helpful if you're preparing for this exam. And this will help you in both theory as well as the Viva. An important aspect of this training program is cardiac imaging. So along with intervention, we do cardiac imaging. So you need to read briefly about the cardiac CT and cardiac MR. And in cardiac CT, you should read the common things such as CT coronary angiography for adults and basic CT which are done in congenital systems such as tetralogy of Fallot. Coming to the program structure, it is a 3-year program, and the structure breakdown we have as follows. So you will get 1 to 1.5 years of interventional radiology posting and a mandatory 1-year posting of cardiac CT. Your posting in cardiac MRI may range anytime between 6 months to 1 year. So this is the overall program structure, how the program goes. And message for the aspirants, why you should consider this program, as this program is specific for complex aortic and peripheral arterial interventions. We do a good number of bronchial artery embolizations, uterine artery embolizations, renal interventions, and upcoming, since we are only an endovascular program, we'll do all the vascular interventions only. And in the MSK, we have started doing arterial embolizations for genicular artery, frozen shoulder, and tennis elbow. And a lot of venous IR is being done. So this is the message I would like to give to aspirants. And I am Dr. Damandeep Singh. I can be reached out on phone and email anytime, and I'll be able to help all the aspirants. I have done from my MBBS from AIIMS New Delhi, MD from PGH Chandigarh, and currently I am DMSR at AIIMS New Delhi. Thank you so much.
Thank you, Daman. So as Damandeep has shared his contact details, I'm sure if anybody have any details regarding the course in AIIMS Delhi, you can contact Dr. Daman. Next, we have Dr. Sai Charan, who is currently pursuing his DM in neuroimaging and neurointerventions from NIMANS, Bangalore. Dr. Sai, if you're ready, you can start your screen sharing and you can start your talk. Yes, your screen is visible.
Yeah, am I audible, sir?
Yeah, you are audible. You can start.
Yeah. So very good evening to everyone. So for the next 5 minutes or so, we'll be briefly discussing about how to prepare for the INISS DM Neuroimaging and Intervention Neuroradiology exam, as well as of how the life of residents in NIMANS who's doing DM will be. So this is already discussed by in the previous sessions, so I'll not be going through this. So just a brief, total number of questions will be 80, and you'll get 1 mark for each correct answer and 1/3 negative marking for each incorrect answer. So in INISS DM neuroimaging, out of total 80 questions, 50 to 55 questions will be from neuroimaging and neuro IR. Rest of the questions will be from general imaging. So coming on to neuroimaging, what topics you should prepare for the examination as listed below are physics of MRI sequences with artifacts. So you can go through the MRI question and answer website for reading this topic. And for diagnostic imaging, you have to be strong in basics of neurodevelopmental abnormalities, especially neural tube defects, particularly the classification of neural tube defects and metabolic brain disorders. More commonly, pediatric metabolic brain disorders will be asked. And you should be familiar with the WHO 2021 classification along with the genetics. You should also be confident enough with the clinical imaging findings in various demyelinating disorders and various biochemical tests which are done to diagnose these demyelinating disorders. There are also questions from various phacomatoses. You should also be familiar with the basic neurodegeneration, that is especially in Alzheimer's disease, FTD and LBD. You should be knowing about the PET imaging patterns. You should also be familiar with the stroke imaging. This is very important. Like everybody who is attending this INISS DM neuroimaging should be confident in stroke imaging. And there were also very few questions which are based on neuroinfection, specifically torch inspections, and also some questions were on CSF biochemistry. So coming on to the topics which are asked in intervention are basic hardware, like the microcatheters and basic embolizing materials. And you should also be familiar with basic angioanatomy and some normal variations. And also imaging related to interventions such as DAVF and AVM, especially the classifications which are used and the grading systems which are used for these two. And you should also be familiar with drugs. Various drugs which are used in intervention neuroradiology. So for preparation purpose, I have specifically prepared from these 4 books. Osborne for neuroimaging, especially the blue boxes. It will help you in saving time and revising fast. And for intervention side, you can go through the AIMS MAMC PJ book. It has given comprehensively almost about the hardware, basic imaging which is required. And this must be sufficient for the INA exam. And if you have gone through both of these books, then you can go through the neuroradiology case review series. This will give you a short case reviews where you can easily see the images and read about the diagnosis and differentials. And at last, for the MRI physics, as I said, it is always better to go through the question and answers in magnetic resonance imaging. This will give a comprehensive details about the physics of MRI. So, and then for someone who is aspiring to take up this DM neuroimaging and neurointervention, this curriculum actually consists of both diagnostic neuroradiology as well as neurointervention. So equally, you will be giving importance to both diagnostic imaging as well as intervention. So for someone who don't want to leave diagnostic imaging, and they should also, someone who wants to keep diagnostic imaging in their career further, they can, this will be a very comprehensive course for you. So coming on to residency in NIMANS, totally out of 3 years, you'll be posted in CT for 5 months, in MRI for 15 months, and you'll be posted for 12 months in DSA, and you'll be having peripheral postings in neurology, neurosurgery, and 1 external posting, 1 month each, and neuropathology, neuroanesthesia, 15 days each. So working hours will be from 8 a.m. to 9 p.m. But in DSA posting, you should be available 24/7 for any stroke calls. And night duties will be once in every 2 months. It will be for a week. So coming on to weekly academics, we'll be having academics for 6 days. 5 days, sorry. So Monday will be journal club. Tuesday will be MRI interesting case presentations. That's a few of the MRI interesting cases which you see in the previous week will be presented on this day. And Wednesday is exclusively for DSA case presentations. Thursday is for seminar. And Friday usually will be a mixture of angioanatomy, DM PhD presentations, and few clinical topics. So coming on to caseload and spectrum in NIMHANS, coming to MRI. So total number of cases which will be done around 140 to 150 cases per day. And every working day, there is 1 3 Tesla machine which is dedicated for GA scans. So good number of pediatric scans will be done. Spectrum, everything in related to neuro will be covered. We also do muscle MRI and plexus imaging, both lumbar and brachial plexus. So coming on to DSA, there are 2 biplane missions. So spectrum and caseload in diagnostics will be around 3 OPDs, 1 to 2 gamma knife radiosurgeries cases. Out of 2 emergency cases, which are usually patients with subarachnoid hemorrhage, and usually we have 2 to 3 intraarterial nimodipine infusions. And intervention mostly are neuro-oriented cases, average 2 to 3 per day. And sometimes we also do head and neck interventions such as percutaneous embolization of JNA, treatment of head and neck vascular malformations. Non-vascular interventions like USG and CT guided biopsy and FNAC done in CT postings. So we don't have a separate posting for non-vascular intervention. So coming on to conclusion, it is also essential to acknowledge that the sobering reality of neurointerventional work, it has its own risks and challenges. The stakes are high, but with even with the minor errors that can lead to a serious consequence of the patient. But as there's a quote like success often comes hand in hand with the potential for significant setbacks, and it is prudent to be prepared for both. Being a rapidly expanding branch with minimally invasive techniques, there are a lot of options in the future. So I would like to conclude by saying a quote. I mean, in every field, there is a competition which is inherent. Focusing on excelling in your craft, and patients will automatically gravitate to the quality of service you provide. So all the best for aspiring neurointerventionists. You can see my contact here. If at all any query or doubts, please feel free to contact me. Thank you.
Thank you so much, Sai. I think Sai's presentation was wonderful. He covered all the aspects of what they do in NIMANS, including the material which he used to prepare. And this last slide hits it very perfectly, that if you focus on your craft, I think patients will naturally come towards your care. Thank you, Sai. We'll move on to the next speaker, that is Dr. Armandeep Singh. He's currently pursuing his DM in Intervention Radiology at AIIMS Jodhpur. Arman, if you can start sharing your screen, and then your presentation will start.
Hello everyone. I'm just trying to share my screen. Is it visible?
Not yet, Arman. Not seeing your screen.
Yeah, is it visible now?
Yeah, it's visible.
Okay, and I'm audible, right? Okay.
Yes.
So thank you to the ISVIR team for giving me this opportunity. I'll be, after this quick talks by Dr. Damandeep and Sai Charan, I'll try to keep a perspective on the DM IR program. I'll be trying to cover it briefly. So my talk is basically focused on the radiology residents who can potentially come up in this field, as well as the medical undergraduates. I hope some of them have joined. But why would you listen to me? I've been in your shoes. I'm still trying to walk the path. So hopefully you'll be able to relate to things that I say. Just to calm you down, why IR? First of all, some diseases are deadly, like an aortic aneurysm or a brain hemorrhage, and their treatments can be deadly also, sometimes dangerous. So how if you could make it a little gentle? What if you could do it through a pinhole? So this is where the interventional radiology comes in. It's cutting a technology without the cutting. This intro is inspired by Dr. Matthew Sir, which I saw for the first time as a radiology resident, and I was so inspired by it. So coming back to the exam, as we know, the the INI-SS exam is separate for the neurointervention part, as Sai Charan mentioned, as well as for the DM-IR program. So as of now, there are two institutes, AIIMS and other AIIMS, as well as the PGI, which is conducting this DM-IR course through this exam. So the number of seats keeps on changing every session. This is the seat matrix for the last session. I'll try to skip this part as it has been covered. So as Pushpendra sir was mentioning, we need to qualify in both the stages of the exam more than 50% of marks in stage 1 as well as combined. The results are given as a common merit list for all INIs except AIIMS and PGI, and an AIIMS merit list for AIIMS and PGI. So based on these merit lists, you get a ranking and you can apply for the seats. Now, giving you a perspective about my journey, I started my MBBS at GS Medical College and KM Hospital, Bombay. I was fortunate to have got the radiology seat in the same institute. And during my residency, I was exposed to interventional radiology, KM being one of the pioneer institutes in our country to start IR in the late 70s to 80s. We got to do a lot of non-vascular interventions independently and assisted in major procedures. I was fortunate to have the shadow of my professors who inspired me. And I also got to present a poster in the ISVR as a resident. So one thing which I would encourage all residents who are having even a slightest interest in IR is to attend ISVR of that year. It will open your mind and will give you opportunity to interact with people of similar aptitude. After that, I came across a lecture by Matthew Sir, and I got to meet him at ISVR, during which he advised me to do an observership, which I did before my results were out, and I finally joined SRship in my institute as a bond period. And during that period, I was giving exams. I appeared in the NEET SS as well, but did not take the seat. And then finally, I appeared in the AIMS exam and I got this seat. So how did I prepare? I think the best policy is to do your radiology residency well. It is better said, I mean, easier said than done, but most of it is the diagnostic radiology training. Majority of the questions will be from diagnostic radiology, and even if you don't practice the MCQs, you will be able to do them. For IR, your basic orientation to hardware is a must, and which I think is pretty easy to get these days. There are a lot of videos, especially on online platforms, where you can get the orientation in case you don't come from an institute where IR is practiced. Basic classifications and everything has been covered in previous sessions. I'll try to skip that. Most importantly, just try to be present in the exam and you will be able to answer a few questions which you have not even read. Brief orientation about the program here we have at AIMS Jodhpur. It is one of the few DM programs that gives head-to-toe IR under the same roof. And most importantly, I come from a place where there were a lot of bonds. So here there is no bond. The department per se is much clinically oriented. We have IR OPDs, wards, own admissions, pre and post-op care, as well as ICU rounds, which I feel is one of the most important points of this program. It gives a good hands-on experience. We have good patient load. Then we have a healthy working atmosphere. It is all the peers that actually lift the place, and the faculty are also excellent and open. And what else would you want? But here are a few things which you should expect when you are planning to join. There are morning rounds, evening rounds, cath lab cases, along with pre and post-op management. There is non-vascular IR being totally done by IR department. Then we have monitoring, discharges, notes, follow-ups, as well as academics happening throughout the week. Now, trying to answer this question, why IR for me? If you are satisfied with diagnostic radiology, I think you might not, like IR. IR is for people who have a hunger to do something more. If you have it, you would work for it. Once you experience it, it's a one-way road. You will never go back to practicing only diagnostic radiology. And if you wish to interact more with patients and solve problems, IR is something you would like. And I feel life is too short to not do what you love. So once you experience it, you will obviously fall for it. And don't let anything else be a deciding factor. This is one of the older photographs I have of the initial few vascular punctures I did at KEM. Now, why did I get into it? I got exposed to this magic pretty early in my life, and I met people who loved it and who became my mentors. Remember, as sir said earlier, you don't choose radiology. Radiology chooses you because of your rank, but IR is a choice you make. So be very clear before going for it. And I remember my professor Ramakantan sir said, it's not a case of aortic aneurysm. It's a person suffering from an aortic aneurysm. The day you realize this difference, the way you treat patient changes. And this is, I think, the foundation of how IR is different from diagnostic radiology. Above all, I feel you should keep it simple. If you make a rare diagnosis, you would be rarely correct. Do what you like, and if you don't know yet, find out. Try to go to places where IR is being practiced. Don't wait for answers, seek them. And in this exam, in the INI-SS exam, the stakes are high, the seats are low. For example, in my session, there were only 2 to 3 seats, and not everything is in your hands. So just do your best and hope for the best. I would like to thank my mentors for guiding me through my paths, and I just hope that everyone finds a good mentor. Interventional radiology is like magic, but real. So this is just a collage of all the different types of procedures we have been doing here at AIMS. Thank you very much.
Thank you, Arman. And I think this was again being told by Ajit sir and Matthew sir, wherein you can shadow them at one of the centers, and that's what Arman did. And like he said, it's helped them a lot. So for anybody listening, that's a good option for you to try out. Next, we'll have Dr. Asim Verma. He is doing his DM in Intervention Radiology at CMC Vellore, which obviously you can select through the NEET SS exam. So over to you, Asim, if you're ready.
Yes, sir. Sir, am I audible, sir?
Yes, you're audible.
So I'll just share my screen. Wow. Sir,
Yes,
is
we
my
can see your
screen?
screen. Yeah,
Okay.
you can start.
Yeah, So good morning, everyone. I'm Dr. Aseem Verma, currently doing my first year IR residentship at CMC Vellore. I would like to thank ISVIR for this amazing opportunity and all my seniors who have guided me throughout. Yeah. So coming on to what is NEET Assess? NEET Assess, like everyone knows, is a common exam for all the DM and DRNB seats, be it private or government institutes throughout the country. Apart from these institutes, AIMS, PGI, JIPMA, NIMHANS, and Shichitra. So DMT seats to NEET Assess has already been covered, so I'll not go through this. So basically, I'll focus on what a diagnostic radiology resident would be thinking, because I was in their shoes like 1 year back. The pattern of NEET Assess is 150 multiple choice questions in 150 minutes, +4, -1, and 0 marks for attempted questions. And it includes, the general thing I heard was it includes questions from general radiology as well as basic questions from IR. But what questions from general radiology and what questions from IR were my questions when I heard the statement? So I've made a gross breakdown of the pattern. So the question distribution is out of 150 questions in my session, around 100 were from systemic radiology, 30 were from interventional radiology, and 20 were from radiology physics. In among systemic radiology questions, a big chunk was from neuro, involving neuroimaging and neurologic related questions, obviously because neuro IR forms a major part of the IR program. Okay. 10 were from genitourinary system, 10 were from GIT, 10 were from chest radiology, 10 were from cardiovascular radiology involving the peripheral vascular radiology, 5 were from endocrine and breast, and 5 questions were also from nuclear medicine that involved radio tracers and PET scans. Now, IR questions, in my session specifically, I found that though the general IR questions were there, like 7 questions were basically about hardware and embolizing agents, there were also questions from neuro IR, which demanded questions like management of stroke, questions like NIHS score, NIHSS, and questions like aneurysm coilings. We had questions from aortic and vascular IR, questions related to aortic aneurysm management, questions related to splenic artery embolizations. We had hepatobiliary IR, that was majorly questions related to TIPS and BRTO. We had IR MSK, which had questions from like genicular artery and vertebroplasty. Onco IR was there, TACE and TARE. And some non-vascular miscellaneous questions were also there. Like they showed an image and asked, was it a biopsy or was it a drainage? Now, physics questions also were there in the paper, and the distribution was 5 of the questions were from X-ray physics and physics. 2 questions were from ultrasound physics, around 3, as far as I remember, from MRI physics. CT physics also had some questions, around 3, and artifacts including X-ray, CT, and MRI were like 4 in number, and 3 questions from radiation physics regarding the AERB guidelines and ALARA principles were also there. Now, the major thing that makes this NEET SS different from other exams like FRCR is it has a lot of image-based questions. So in my session, there were around 50% image-based questions and 50% text STEM questions, around 80 text STEM and 70 image-based questions. Now, for among the image-based questions, 40 were direct spotters. Like if you will face in your MD final exams, or if you have given DNB, you get an OSCE session. They were like those spotters, and 30 were clinical STEM STEM with images, including clinical images from pre-procedural planning for an aneurysm coiling or a stroke. So to ace all of this, to ace NEET assess now, because the pattern is so extensive, the first and foremost thing is to report as many cases as possible, because we also had like full-fledged MRI and CT films given and asked about the possible management of the case. Now, I would stress on the fact of making concise notes, because like any other, all of the people sitting here have cracked NEET PG, they have cracked NEET UG. So revision will be the key to ace any of these exams, rather be it NEET SS or INA SS. So revision, and for revision, you need to have your own notes. Osborne, Webb, Granger, and all Granger Essentials are must reads, obviously. But one underestimated source that I felt personally was Radiopedia, it is such a powerful source, such a powerful material, because it's like in your phone rather than your phone being a distraction. You can easily use Radiopedia. It's readily available, and also because 70 questions are images, it'll help you immensely with various clinical images. FRCR 1 and 2A books are helpful. Fast physics, for machine, crack the core. But the problem is, again, FRCR 2A is basically clinical STEM text-based questions, but you have a lot of image-based questions in need assess. So you need to cater to them. And FRCA 2A, FRCA 2A MCQ books will help, but again, image-based, they're not image-based. So for image-based things, I'll definitely recommend you to go through spotters from various online sources, from your books, and various Telegram groups that those are available. For NEET SS specifically, and for the IR part, I found Krishna Kandarpa. You need not go ahead. Kaufman for vascular IR and Harrigan for neuro IR, I might suggest for INISS, but for NEET SS, I don't think it's needed. So now regarding my day, like I'll just go take you to a visual walkthrough to IR residents day in the Department of Interventional Radiology at CMC Vellore. So we have two campuses in the IR department spread across the two campuses. This is the Vellore campus, which is the old building, and this is the new Ranipet campus. So in the Vellore campus, we have our own interventional radiology OPD. We have a mini DSA, and we have a main biplane DSA. And we have rooms for ultrasound guided interventions as well as CD guided interventions. And coming on, and we also have a ward, definitely. We admit our own patients in these wards and take rounds. And in the Ranipet campus, I really like this pick, and the way CMC Vellore calls its department as a department of clinical radiology, which has two subdivisions, the Department of Radiodiagnosis and Department of Interventional Radiology. Again, we have a consultation room within, and in the main OPD as well, we have two interventional radiology OPDs. Then we again, like in the Vellore campus, we have a mini DSA in the Ranipet campus as well as a main biplane DSA. So we have a total of 4 DSAs, 2 biplane and 2 mini DSAs. We have rooms for ultrasound guided interventions and CT guided interventions as well at the Ranipet campus. And again, in the Ranipet campus as well, we have general as well as daycare ward beds. So for the IR department at CMC Vellore, it's a holistic and extensive IR care approach. We get exposure to head-to-toe vascular interventions. There are a lot of number of cases. We get 5 to 10 DSA cases per day at Vellore campus, 10 to 15 DSA per cases per day at Ranipet campus, and numerous non-vascular interventions are also there, like biopsies, drainages, ablations, and various nerve blocks for pain management. OPD exposures, we get national as well as international patients from Bangladesh, patients from Bhutan, and at the Vellore OPD, there's a footfall of 10 to 20 patients per day, whereas in the Ranipet OPD, we have 30 to 40 patients per day. Emergency exposure is there. We do a wide spectrum of emergency cases like stroke, neurocoilings, SAH, bleed embolizations, and we also help and assist other departments in their wards and OT when called for. Then ward care is there. We have a general and daycare wards, and we do regular rounds. There are morning rounds, there are evening rounds. We do pre-procedure assessment. We do post-procedure follow-up. At CMC Vellore, it's a mentee as well as a mentor approach. We have classes by a faculty and an adjunct international faculty. We have a regular MDTs with different departments. So here we are students, but we are not just students, we are also teachers. We have DM, PG, and fellow teaching sessions in which we interact with the UGs and PGs, and we present with them, we teach them, and again, we have projects and publications. Well, coming on to duties, I personally feel an IR is always on call, but because the presentation needs it, we have a weekly rotations between the Vellore campus and the Ranipet campus, and officially, when you're posted in the Ranipet campus, you're on call for emergency duties. But as I said, I feel an IR is always on call. For accommodation, we have accommodations at Vellore and Ranipet, which are decent. The community life at CMC Vellore is something which I really like. It's a very close-knit hospital with a very friendly environment. The seniors, fellow residents, and hospital staff is very friendly. And I personally have done my education for the past 10 years in Delhi. So I was really concerned about the language issue because it's Tamil Nadu, but here, language is not a barrier at all. It's a very conducive environment. And again, Vellore gives you a myriad of opportunities to attend conferences and CMEs. It gives you opportunities to learn and present at national and international conferences. socialize with fellow IRs from across the country. And CMC Vellore holds its own CME, the Yorkshire Vellore International Radiology CME. So basically, these are picks from last year in which we have national, international faculties for a 2-day CME. And we have IR residents from various colleges across the country coming and learning under the aegis of these pioneers of their respective fields. So thank you. This is my pick of the last ISVIR, and I hope some of you find your way to the next ISVIR, and I'm hoping to meet you soon in the next ISVIR 2025. Thank you.
Thank you, Aseem. Again, wonderfully covered, very elaborate in terms of the questions. You have also made a note of the split up of the questions that were asked. So if anybody was viewing that, I think that's a very important pointer for you to take home. Next, we have Dr. Abrar. He's doing his DRNB intervention radiology at Kovai Medical Center at Coimbatore. Dr. Abrar, if you're ready, you can start sharing your screen.
Yeah, good afternoon. Thank you for the opportunity. Am I audible?
You're audible, Abrar. Can you start sharing your screen? We can't see your screen yet. Yeah, it's visible. You can start.
Okay. Good afternoon, sir. I'm Dr. Abrar, first year resident from KMCH. Today I want to talk about NEET SS DRNB program. First of all, it's a path from radiology to interventional radiology. One of the ways you can do it, the aim of the program is to make you a comprehensive interventional radiologist from head to toe across all body systems and imaging and modalities. Selection is an online counseling based on merit list option entry as per your MCQ scores. It runs in 2 rounds with a mop-up round. Applying, it's through the NAT board website here. It's annual NEET SS exam. The question paper consists of 150 questions over a period of 2.5 hours with 25% negative marking for incorrect answers. Most of these questions are radiology questions, which was well discussed previously, and with some basic IR questions. As coming to how to prepare, other than your regular radiology book, last few days you need to have a good radiology review material. I found Crack the Code to be very helpful in that, and with some basic interventional radiology knowledge about the hardware, the more common procedures, contraindications, indications, and the conditions which we perform in, and with pharmacology of the usually used drugs like antiplatelets, anticoagulants. Then the centers available for DRNB across India are Max and Gangaram in Delhi. Then we have Medanta in Haryana. Then Rabindranath Tagore International in West Bengal. Coming to Karnataka, we have Narayana and Sakra World. In Tamil Nadu, we have KMCH, Kuppuswamy Naidu Memorial, Tamil Nadu Government Multi-Speciality Hospital, and Kerala has Aster and Kerala Institute of Medical Sciences. Now, coming across how to choose your center and what expectations to have. First of all, you need to have a right mentor, the infrastructure, the spectrum of cases, the hands-on opportunity, the teaching program, and of course, the credibility of past students too. What to look in an ideal mentor, he should be an inspirational leader, should be willing to teach and available in lab and outside for problem solving and guidance. In this aspect, I count myself very lucky to have mentor like Dr. Matthew Cherian, Dr. Pankaj sir, and Santosh sir. And ideal infrastructure, taking KMCH as an example, we have RT's biplane cath lab with large display monitor. There's a single plane that is dedicated for radiology. There's ultrasound and Iverson lab, angiojet, microwave, RF, and cryotherapy for ablative procedures, CT for non-vascular procedures, MRI, which has a priority for stroke. There's a PACS and server-based workstation across the department. There's a large armamentarium of hardware. And case distribution in KMCH, we do a lot of neurovascular, which mainly includes ischemic stroke, AVMs, dural AVFs, ICAD, carotid stenting, aneurysm, tumor embolizations. Then in periphery, we do angioplasty, stenting, thrombolysis, embolizations. We also do a lot of aortic interventions. Then venous system, we do DVT management, but JRA, filter retrieval, then portal vein embolization, dips, and a lot of ablative procedures and varicose vein therapy. And hands-on first year, we usually get to perform diagnostic angios. We assist in a lot of common procedures and ward rounds and duties. Second years, again, peripheral interventions, duties, OPDs, ward rounds. Third year, some neuro intervention basic procedures are available, stroke work, then duties, OPDs, and ward rounds again. So the teaching program at KMCH across the week, Mondays we usually discuss interesting case of the week. Tuesday we discuss the NBA class that was held previous day. Then Wednesday, another interesting case of the week. Friday we do a journal review. Saturday there's a discussion on theory paper questions. Okay, credibility of past students matters because it helps you a lot with employment opportunities. And KMCH, we have a zero fallout with 100% employed. We have recognized past students like from US. We have Sanjay Prasad Kalvasar. Then UK has Dr. Krishna Prasad, Dr. Vijay Kumar. Kerala, Doctors Manish, Rahul, Dilip, Rinash, and Shahir sir. Tamil Nadu and Andhra, we have Mutturaju, Alango, Karthikeyan, Anup, Ravi Kumar, and Nikhil sir. Maharashtra and Gujarat, we have Dr. Saurabh, Jenny, Dhrav, Santosh Patil sir. And Punjab and Rajasthan, we have Sitaram and Akhil sir. So other factors that can be considered but not given a major priority would be accommodation, which is average here to say. Then working hours here, the usually days goes from 8 a.m. to 6 p.m. depending on the cases. We alternate between OPD and lab tests with vein clinic and vascular imaging included. Then there are rotatory duties, which can be a bit busy because we take first call for stroke cases. We also have trauma codes, GI bleed, PPH, etc. So in conclusion, interventional radiology of course continues to play a increasing vital role in patient care, offers safer and efficient alternatives to traditional surgical procedures. DRNP program should ideally prepare you to work independently across across head-to-toe procedures. Ensure your mentor is good because, of course, their level of training decides their level of expertise decides your level of training. So choose your centers wisely. Thank you.
Samarth? Samarth?
Okay.
Thank you, Abrar. I think Samarth is
Okay. Thank you, sir.
I think Samarth is log out because of the low battery.
Oh.
So who's the next? Who's going to present next? I think it is over.
Sir, there are two more this thing.
Yeah,
One
Avinash.
is
So,
myself. Yes, sir.
yeah,
Yes, sir.
Avinash, so Avinash is going to take over. Avinash, you
Yes,
start
sir.
that. Yes.
Yes, sir. And so we have two more, a fellow perspective of fellowship and their perspective in IR. This particular talk is I'm doing it myself here. So I'm just sharing my screen, sir.
Yeah, hello Ajit sir. Apologies from Dr. Samar's side. He just got locked out because of the internet issue. So Dr. Avinash, could you please start your presentation now?
Yes, yes, I'm trying to share, but I'm not able to. 1 second. They asked me to quit and reopen. I'll just log in and log out and log in again.
Yeah, sure.
Thank you.
So while we are waiting for that, I think we have many questions in the question box. And one of that question is any DMRD can take the fellowship or the DRNB or DM seat? So I think for DRNB and DM, you should have an MD degree or a degree in radiology. But few of the fellowship centers, they can take you as if you are having DNB and after DMRD and after DMRD, if you have an experience in SRship in radiology, maybe 1 or 2 year, some centers can take you as a fellow in interventional radiology. But my suggestion to you is better if you go for the secondary DNB, and then you can have more options of applying for DNB or DRNB or DM or the fellowship. But if you don't want to do the secondary DNB, you can have 1 or 2 year SRship in radiology, and then you can apply for uh, the IR fellowship program. Better to do the SRship from the same institute where you want to do the IR fellowship, so that your mentor can get to know about you, and then easily you can get the fellowship. The other questions are already answered by Dr. Pushpender. If still you have any questions, you can ask in the comment box. Dr. Pushpender and me and Dr. Matthew is there to answer you. Dr. Avinash, please.
Am I audible, sir?
Yes, you're audible.
Can everybody see my screen?
Is clear.
Okay. Good evening, everybody. Thank you very much for attending the session, and my personal thanks to ISVIR Senior Committee for giving me this opportunity to talk about my experience in fellowship. So actually, IR, I have not discovered it until my post MBBS. It's not like for many people as a radiologist, they discover IR. But for me, I was lucky enough, like what happened to Sham sir, somebody has suggested him IR. I was very fortunate to get a senior who has guided me at the time of my NEET PG counseling, that if you take radiology, you can prospectively look into IR. And that's when I got into the idea of looking into IR. So at that point of time, I have done my research and chose an institute which has a very good strong IR program. So myself, I'm Dr. Avinash, and I'm currently working as an intervention radiologist in Miyot Hospital, Chennai. I'm also a junior council member in ISVIR Junior Wing. So it doesn't go by saying, as Matthew sir has mentioned, it's important to have a good mentor, especially in fellowship, because in NEET, DRNB and DM, you choose the institute, but as a fellow, you choose the mentor. And it's very important because without the mentor, without the mentor and his feelings, doing a fellowship is of no use, because you won't be good enough to do the procedures by yourself. So that being said, when I started my DNB PG in Miyot Hospital, Chennai, Dr. Murali Krishna Swami was the one who is a HOD at that time. He's 25 years into intervention radiology. He's one of the pioneers of intervention radiology, and he is the first person who has given me my first puncture in the end of my first year. And as Matthew sir mentioned, failure teaches a lot of things. I never got my first puncture, neither venous nor arterial, but he didn't scold me. He didn't give up on me. He taught me exactly what to do, how to do. And that first puncture has hooked me to IR. And this happened in the first year of my residency. Since then, I'm a very 1 year into 2 years into intervention radiology as a certified person, but I've been doing IR non-vascular procedures and basic FNACs and biopsies even in my first year of radiology, thanks to Murli sir. And on the side, you can see my current mentor, Dr. Karthikeyan Damodaran, a well-versed person who's very good in protocols. It's always fun to discuss cases with him, and I always learn every day basis. So choosing your mentor is very important, and that's how I got into intervention radiology. So this is my hospital. I work in Miyot International Hospital. I did my PG from here, and I was fortunate enough to get a fellowship here, and I'm the first fellow here, so there was no previous person for me to say how the fellowship goes. But on first-hand experience, I can tell you that this hospital is full-fledged multi-speciality hospital. So you have a wide range of cases. I don't want to go into particulars because my previous presenter has given all the information that you have to look into when you are choosing an institute or choosing a DM or a DRNB institute. Coming to fellowship, I agree with Pushpender sir, correctly pointed out that in fellowship, the interview is the biggest thing. You are clever. That's the reason why you got radiology. Your IQ is off the charts. But what comes to the picture is your interest into the IR. And trust me, the person sitting in front of you who's taking the interview knows and has seen a lot of people. They can like this find out whether you're interested or not. And your exposure to IR doesn't matter how much small it is. They'll ask one question and decide whether you do know about it or you don't. So interview is the key. Don't lie, or don't try to fool the interviewer. Be honest. You will get it if they see an honest answer in you. Okay. And this hospital, it's a 1,000-bedded hospital, so we have wide spectrum. I'm not going into the spectrum again. My previous presenter has shown all the spectrum of cases that can be done in a multi-specialty hospital, and we carry the same. We do neuro and vascular, but as of now, there is no neurointervention radiologist in-house. So we do DSAs and other things, and we get a neurointervention radiologist from the outside to do the cases as such. But intracranial, yes, but extracranial, everything we do. And I've been in this hospital for almost 5 years, and I still get cases which are awestruck, and I run to my mentor to see how he thinks and what is his troubleshooting method in a certain case. So mentor is always good. The working hours and emergencies, again, 24/7, 365 days. If there is a case, yes, you're saving a patient, you're not just doing the procedure. So your availability and everything is important. And for just an example, you can see on the corner, I just blurred it out because there was patient details, but this is how a monthly calendar of our IR looks. We everything add into the calendar. Since it is all, we have only 2% department, so we have to be available all the time. And these are the case, just an idea of how our day-to-day routine will be. We try to finish it by the end of the day. There is a good work-life balance as well. So this is the things we do, and our institute is predominantly tertiary care center for ortho. So we get a lot of trauma cases, a lot of bleeders, and MSK is predominantly treated here. So we do pain management as well. In most of the centers, anesthesia does the pain management, but in our case, we do injections and pain to a certain extent, the pain management blocks and everything. Our regular day involves tumor board meetings. Occasionally, we do M&Ms depending upon our cases and other cases if our involvement is there. So me being the first fellow, there is another fellow currently working. So, and the fellow's responsibility is we'll be there, we'll be supervising everything, but non-vascular cases, you guys do start immediately if you have a prior training. Publication and poster presentation, everything is important, sir. I mean, he encourages it to do it. Recently, our fellow has presented a paper in ISVIR in Thailand. So, but our major cases are referrals, because we do cases like hepatobiliary and other gastro cases and MSK cases, all has ties to different departments. So with referrals are our main this thing. That being said, we have our own OP, and our each day on an average we see OP of 10 to 15 per day in the afternoons. And there are so many walk-in patients, as our previous speakers told, that you have to talk to the patient, you have to clinically examine the patient. Once patient know your face, even now, sometimes the patient comes running if there is a problem in the pump catheter, if there is a problem in some stent or a PTBD post drainage, people come to you, to your OP to see, can you check out this tube, not to your major first referral who is a hepatobiliary, because they know your face, they know that you have done the procedure, so they know that you are the person who knows the great idea about it. So presentations we occasionally do. We don't have a structured seminars or something. So because we have a wide spectrum of cases, but unfortunately we don't have so much of volume. So every day the spectrum changes. We might do neuro case in the morning. After that, there might be varicose veins. After that, there might be PTBD. After that, it is altogether celiac plexus block. So the case discussion happens among us for the next day cases. So we review the images. We ask the fellow to ask his approach over it, read the cases, read the presentation read the papers on it, and the next day the discussion will follow based on the cases of that day. And we always have a radiology PG every month in rotation. We get a radiology PG, so that's how I got into IR as such. So I prefer, like, if you guys are having IR, please do ask for a posting there. If you guys don't have an IR, it is in the curriculum of DNB or MD radiology exam. So you can ask your management to have a MOU with a nearby IR hospital so that you can have exposure right now, and later you can decide. And there is always an observership which you can do, whether you find out whether you can do it or not. But I would say go for a posting there, see on a monthly basis or a 2 monthly basis to understand what exactly has been done. Over a period of time, you might find it very interesting. So coming to the fellowship, there is all information in ISVR website under the career section. You can get the person to be contacted, their email ID, and the fellowship as how long it is and how many seats are available. You can always contact. But in general, the fellowship program goes out. The brochures goes out around August or September, and October and November is the time of joining the courses. And choose your institute very carefully, because it's very important. If you have gone into an institute or looking forward to do IR, your mentor is the key again and again. So my conclusion here is go for an observership or a MOU with your hospital if you don't have an IR department. Attend ISVIR workshops. Every year ISVIR has a wonderful conference in which there is a dedicated workshop sessions every either end of the session or 2 days. So they give you hands-on. They teach you how to do it. Non-vascular procedures like we do even pleural tapping, SAT tapping. We do because there is a radiology PG. I make them do that. I stand there and try to guide them so that they can understand and see if their hands are made for IR. And selection of a center and mentor is the key. There should be wide range of cases, even though it is not hundreds of it. But if you come across 5, 6, or 10, or whatever might be the number, if you come across it, each case is different. Each particular approach is different. And once you are if you discuss with them, if you understand the physiology and things, the basics, only then you can play with the catheters and everything, and then you can be more creative. I'm pretty sure, like how Matthew sir has mentioned, when they were trained, it was all basics, but now he is the person who is the magic person, and the same follows to the rest of the people like Sham sir and Ajit sir and Pushpender sir. They know basics very well. So when you know basics very well, like my mentor says, when you know how a catheter behaves, you know how to play with it. And finally, the patient and attenders. Radiology is all about white collar thing, they say. You don't have to see the patient, you don't have to talk to the attenders, you just have to dispatch a report and let the clinician deal with it. Let the clinician explain the news and all. But being a radiologist, you have to be mentally prepared, you have to talk to the patient, you have to talk to the attenders, you have to explain them the procedure. Ultimately, you are making a nick on the patient's body. So you can't say, I'm not going to do that. Be ready for that even before considering yourself as an IR, because if that is not your forte and you don't want to deal with that, then IR is not something that should be considered. And my personal view in fellowship is don't go for the fellowship in the first go. Prepare for DM, prepare for DRNB. If you're up for it, you crack it, yes. But if no, then you can go for fellowship. But fellowship, no matter what, DRNB or fellowship, if you are learning something about IR, it stays with you, it grows with you, and you can do. So thanking you, the team and everybody. And these are the people, I'm junior wing members of ISVR. If anything, you can contact us. Any one of us will be very glad to help you out to sort out things. And this is the whole reason I remember Ajit sir in the earlier stage, he told that the whole purpose of you guys and the whole purpose of this junior wing is to academically educate ourselves. And second thing is to be a bridge between the youngsters who are afraid to ask questions. So we are all open to anytime, any question, we'll be helping you out. Thank you very much.
Thank you, Dr. Avinash. I think it was a wonderful talk, especially after all the DM and DRNB talks. This gives a fresh perspective about a fellowship program. And I was really inspired by the last note which you made, that even if you do not get a 3-year course, considering the number of seats, if you still love IR, there is always a way you can get trained yourself and keep going. I think this is something which we all can learn from your talk. So thank you once again.
Thank you very much. Sir.
And moving on, I would like to invite Dr. Amrita, if you could share your screen. Yeah, we can see your screen now, Amrita.
Good evening, everyone. So I'm doing fellowship in VIR KEM Bombay. So just to summarize the fellowship options, there are, as sir said, around 40 to 50 seats. And these are few websites where you can get individual feedback of the institute. So I'll just summarize fellowship in KEM. So the admission process for fellowship in KEM is a centralized admission process through Maharashtra University. Here, the marks are assessed right from your 12th grade MBBS MD, number of attempts for MBBS MD, and domicile of Maharashtra is given priority. So points are given to everything, and as per the marking system, you are given a rank, and then you fill the form, preference form, and this form usually comes around the month of Jan, and joining is done by month of April. So in KEM, there are 2 separate fellowships, that is 2 seats each in VIR as well as in INR. This is a 1-year course, and number of seats, as I said, is 2. Stipend might vary from institute to institute under MUHS. In KEM, it goes as per the stipend of SR. So there is an exit exam which is held by MUHS, and it is usually a practical exam. So the work pattern in VIR, here there are alternate day OTs. The OT is shared by INR as well as VIR department. This is a biplane cath lab. So on OPD days, one has to take the morning rounds around 8 a.m. Then the OPD starts from around 9 a.m. to 4 p.m. These are official timings, but whenever there is a call or any OPD call, one has to attend it. So in OPD, one has to assess the case, that is take the history, examination, get the CT scan report, ultrasound, MRI lab reports, whatever is required for the case. Then you take the cases, that you accumulate all the cases, and then finally go for senior discussion. Kranti Kumar sir is my mentor here. So we discuss case with him, and then a management plan is given accordingly. So if it's an elective procedure, we give a date, and if it's an emergency procedure, we plan it accordingly. So along with this, the other fellow takes care of the OT next day. That is, one has to take care of the admission of the patient under VIR department, prepare the OT list, workup of the cases, technical aspects of the procedure, anesthesia if needed, what type of anesthesia, and what your inventory is required, one has to keep that ready. So on OT days, as every day you have to take morning rounds, and OT usually starts by around 8:30. On OT days, the first thing in the morning is to keep everything ready for the day. That is, the procedure inventory has to be kept ready, the imaging films has to be kept ready, and plan the sequence of the cases so that you can manage when to ask the patient to be NBM. That's another aspect, how to plan the cases throughout the day, because usually it goes till around 12 a.m. in the night. So you have to plan that. And 2 fellows are there. One fellow always scrubs in, and the other will see the outside department. That is, whatever emergency calls are there, or let's say if one has to assist, the 3rd assistant is required. So another fellow also scrubs in. And there's alternate day for even fellows. So this is just a brief summary of last spectrum of cases that are done in VIR. And I have personally seen this, assisted this with sir in last 1 year. So portal hypertension interventions, that is TIPS, DIPS. Usually there is one case every single OT, hepatic vein stenting, IVC stenting, PARTO, BARTO, PTBD, HVPG. Then mesenteric ischemia management. GI bleed cases are very frequent, and that has to be considered as an emergency. So you have to be nearby the campus, as only fellows manage this. Then genitourinary tract system, AML embolization, renal angioplasty, renal stenting. So all these are planned, how to approach in OPD during the OPD hours, and how to go ahead with it. Sir is there to assist, to watch, but you get the hands-on. Then vascular cases, that is peripheral arterial disease cases, angioplasty, stenting. Major aspect of this is whom to operate and what cases there has to be knee endovascular management, that you learn throughout the your 1-year fellowship. Then sclerotherapy, peripheral AVM embolization. In OBGY cases, usually this comes as an emergency procedure, that is bleeding in cases of uterine artery embolization, fibroid, or let's say there's a placenta, adherent placenta. So preoperative prophylactic balloon assisted occlusion has to be done. Then in respiratory system, bronchial artery embolization, pulmonary AVM embolization, or if there is any Rasmussen's aneurysm, dialysis related procedure, usually 1 case per day is posted, that is permacath insertion, fistuloplasty, CVOplasty. Endocrine procedure, adrenal venous sampling, inferior petrosal sampling in MSK, ablation, embolization, or if there are any METs, the embolization. Aortic intervention, throughout the 1-year fellowship, one thing I've learned is what aorta cases have to be planned, how to plan an aorta case. That is whether you can go ahead with intervention or whether it is surgical procedure. That you will learn in 1-year fellowship. You do get to wash in the aorta case as an assistant to sir. I think I've summarized most of it, which is done under VIR. Neuro IR is a different department in KEM. And there are different fellows for that. There are different fellowship seat as well. So pros of fellowship in KEM is there is good hands-on training under supervision. There is wide spectrum, ample cases for hands-on training, no allied posting in diagnostic department, publication of the cases are done. There are lots of CMEs which happen around the KEM. So there is an IR meet, Mumbai meet, where not just KEM, all the other 4 departments, 4 colleges, that is your Tata, JJ, Sign, all of them meet once a month and cases are discussed. So that gives a overview of what other procedures are being done around the college or around the city. I think I've summarized the fellowship part. Yeah, thank you.
Thank you, Dr. Amrita. That was a very concise presentation regarding the fellowship pathway in KEM hospitals. Again, thank you everyone, especially the candidates who have in detail described about their fellowship pathways in their particular institutes and how, in specific about how to prepare for these exams. We are now moving to the end of the presentation. I'd like to apologize because we're all running a little bit short of time, but then we have a last question and answer session, which we'll be getting to. I'd also like to say that we have with us Dr. Sanjay Yadav sir, who was very instrumental in making this happen. Sanjay Yadav sir, as we all know, has this famous Telegram groups and teaching sessions online through which a lot of radiology residents take a lot of inspiration from. So thank you, sir, for always motivating us. And I think you serve as a perfect bridge for candidates who want to take up IR in the future, who are pursuing radiology currently. So if sir could say a few words, sir, all of us would be very thankful.
Good evening, everyone. I sincerely thank the ISVIR Junior Wing Group, especially Dr. Darshan and Dr. Samar and the entire Junior Wing for taking so much pain and difficulty in organizing this review course, or what I would say like a channel for the radiology residents. In future, how is the scope for the IR, which IR they can opt, whether DR, DNB or a DM IR or a fellowship. It's a wonderful platform. I've asked Darshan to make a recording and share this in a YouTube page of the ISVIR Junior Wing also, so that it will be there for lifelong. Whoever residents, radiology residents, especially while doing the residency or after the residency, they can always go through this video and get to know. And I sincerely thank Matthew sir, Ajit sir, and all Pushpender sir and all the senior faculty for mentoring so many students and guiding them in the right track. And main address to the residents, I want them to wake up. Most of the residents, whenever I talk to them, what you want to do is always the answer they want to sleep, they say, because they're so tired and exhausted in their own residency. They don't have patience to look beyond their residency, beyond the cross-section imaging, what they do day to day. They hardly like to interact with patients, the current generation. So you need to wake up, come out of your shell. It's not just always reporting in the dark room or reporting in the gray and white. So come out of your shell, try to interact with the patients. As Ajit sir said, you can just start off with your small intervention, at least from the ultrasound guided. Try to interact with the patient, knowing the history. Most important, they try to hesitate to talk to patient, to know the history, to follow up the cases, and post procedure what they have done, how is the patient doing, at least during your residency. This will be like a stepping stone before you enter into IR. So most of them hesitate to take up IR. See, when the gastroenterologist or a neurologist residents can coming forward to do the intervention, why not a radiology resident? You should be more enthusiastic and more passionate if you're interested to do dedicatedly IR. It would not take much time because there are wonderful teachers out there who are ready to train, teach you, and mentor you. I don't think any part of the world such wonderful training you would get. I think this is the best teachers in the world, I can tell you, in India, where you have a IR faculty. So do make utilize of them. In your residency, whenever you find time, do attend the ISVIR conferences, because I have attended few where you have proper hands-on, you have the skills to know on the mannequins, as well as the skill labs are kept in the conference. So you get an idea, how is a catheter being placed, a sending a technique being done, what are the minor procedures, biopsy, FNSC, or even a pictal, how are they being done? So please do make time and attend the conference so you get a vision and idea. Other department or branch people are jumping around to enter into IR and start doing, because the current generation are not showing so much interest. So I request the residents, don't always think in terms of monetary gains, or don't always think I want to settle quickly, I want to earn very quickly. Definitely money will come to you. As you can see, Matthew sir is the highest earning as of intervention radiologist. So I wish all the best and good luck for the younger generation residents to think seriously about intervention radiology in future. In the long run, it will definitely be helpful to be a fruitful career, as well as call it as a good clinical intervention radiologist. Thank you so much. Thank you, Darshan, and the entire ISVIR Junior Wing team for arranging this webinar today.
Thank you so much, sir. Again, very inspiring to hear your words. We'll always look forward to your sessions, of course, on Telegram. Thank you so much, sir. So finally, I think we'll just spend the last 5-10 minutes discussing about the questions. I'd like to say that we had an overwhelming response, more than 150 questions from all residents across India. So we have shortlisted them to around 10 questions. So we'll be spending the next 5 minutes answering these possible questions. One of the common questions that we were asked was, how difficult is the transition from DR to IR? How difficult in terms of clinical skills, work-life balance, satisfaction, and can we have an easy lifestyle of diagnostic radiologist while doing intervention radiology? Shyam sir, if you could take this question.
Am I audible?
Yes, sir. Yes, sir. Audible, sir.
Okay. I think it's a very important question. I must say that during diagnostic radiology itself, we will be starting the transition because we will be oriented to image-guided biopsy procedure, night duties. So I don't find it's a difficult task at all as far as person is interested. Hope I made it clear. Thank you.
Yes, sir. Thank you so much, sir. The next question is regarding losing touch with diagnostic radiology. So after starting IR residency, is it natural to lose touch with diagnostic radiology, and how to overcome this if it becomes an issue in the future? Matthew sir, if you could answer this particular question on how to deal with this. Hello. Pushpinder sir, could you shed some light on this, sir?
The more you go into IR, you will know more about the diagnostic imaging of that particular disease or the spectrum that you will be treating with. You will get very good at, say, diagnosing a HCC if you are going to treat if you're in a hepatobiliary center, or you'll be very good in interpreting the CT angiography images if you're doing a revascularization procedure and all. But yes, you do lose touch with specialized diagnostic radiology like MSK imaging. That is one thing that's there. So it's a trade-off between, say, high-end diagnostic radiology. You will definitely remember the basics that you have done during your residency, But yes, you after a while you do lose touch with diagnostic radiology.
So I think Dr.
Thank
Pushpender,
you,
this
sir.
is the same thing as the general radiol surgeons. General surgeon, if someone is
Yes,
taking
yes, sir.
neurosurgery, neurosurgery, if
I just
general
came
surgeon
back.
become neurosurgeon, then is why you want to do a cholecystectomy? So it's similarly like if we are in IR and if I am doing a hepatobiliary work, why I should do a neuroradiology work? Why I should like other imaging? If I am restricted to my IR work, so I can do the some of the diagnostic work of the that related to my IR. I don't have to do the routine work of the radiology because I'm like I have my full hand with the IR work in the full day. So don't uh, put your feet in the both the boats. If you are going to the IR, better you should go into the IR. Let the people who are interested in the diagnostic, let them doing their work in the diagnostic.
See,
Thank you,
Ajit,
Ajit sir. About
just one
yes, sir.
thing.
Continue, sir.
One thing, I totally agree with Ajit in the fact that if you are into IR, there is no point in doing diagnostic work which is not IR related. But I also want to talk the other extreme. I find IRs totally losing touch with diagnostic imaging, which is connected to their work, which is also wrong. Now, for people like us who do whole body IR, we are pretty interested in everything to do across the body in imaging. I'm not very interested in white matter diseases and stuff like that, which is no, but definitely when or I'm not so bothered about WHO classification of gliomas and tumors, but I would definitely want to know everything about stroke, everything about aneurysm imaging, anything about vasculitis. So we are the ones who drive the protocols for doing vessel wall imaging, the kind of vessel wall, we do a lot of that. Or for example, even when it comes to a patient who comes to us for example, an AVM, uterus is sent to us, and we image because we know half of them are actually choriocarcinomas, and if you're going to directly take an AVM, it's a disaster. So what I'm trying to say, our biggest strength is the fact we know imaging, and we should know all the imaging connected to our work very well. I'm totally clear about that. I know some people may not agree, and we do take help sometimes from a colleague who's good in that area, but we are very sure that we know our area well. We are like surgeons, unless I'm convinced I won't touch the case.
So I think Dr. Matthew ने जो कहा ना वो बिल्कुल ठीक है, and we can actually divide our work. Like in my department, myself doing most of the lymphangiography work and the thyroid work. So I am doing MR lymphangiography by myself, even thyroid contrast ultrasound by myself. My colleague Dr. Raghav is doing MSK interventions as well as body interventions. So he is doing all the MSK ultrasound by himself and also read the MSK MRIs also. And Dr. Arun, who also read all the CTs by himself and see all the CT for HCC, for tips and tear. So if you are thinking you don't want to lose, but you can go into the subset of radiology also. Like I am not more into the MSK radiology, but my colleague is there. I am more into some of the branches I want to pursue, and I can do all the imaging of that.
That is the only way you can generate patients also. You understand? So sometimes my fellows, I get upset. I say, take care of the vascular lab because you generate patients. You talk and say, sir, there's an occlusion over there. We can take my angioplasty. Because many of our diagnostic colleagues don't actually promote IR. They just report and leave it,
Yes.
So at least in the area of interest, if you're able to do, as for example, if you want to get more ablation cases, you have to go for the tumor board meetings. And you have to talk with the tumor board and say, let me ablate. So that's one of the way to generate patients also.
Thank you, sir. So regarding another question which was commonly asked regarding salary. So when compared to diagnostic radiology, does IR offer a substantial advantage? And if so, an IR, is it neuro?
Double of a diagnostic. But then you spend more time. So you understand, for example, after your 3-year DM course or equivalent, your starting salary will be somewhere around 3 to 4 lakhs. Unless you join a government hospital, and private centers, they offer that.
Yes, sir. Another question. If you're doing an intervention radiology residency and post-residency, do you stick to pure IR or do, say, corporate hospitals and medical colleges, will you have to go back to diagnostic work again? Is that an option that you can have?
That is very dangerous. If you say, I will also be reporting, no. You don't have to officially report anything. You report for yourself. But don't get into the reporting pool, then you will find it very difficult. They'll say, no, finish your CT, finish your ultrasound, only then go for your IR cases. So IR is just like a cardiothoracic surgeon. He doesn't go into echoes. I don't think we should.
Yes, sir. So I think most of the corporate hospitals, initially when any IR is joining, they will join as a MG, minimum guarantee of some amount. So if let's say they are saying 3 lakh rupees, so they want to do some of the DR work also, diagnostic work. So उनको एक रेडियोलॉजिस्ट नहीं रखना पड़ेगा, उतने में अगर आपका 3 लाख रुपए का काम कर देगा अगर डायग्नोस्टिक का, तो IR एकदम से फ्री में काम हो रहा है एक तरह से उनका. So don't fall into trap after you're doing your DNB or DM or fellowship. Always go to the corporate hospital and say that I will do only the IR work, not the reporting work. As Dr. Mathu is saying, only do the imaging of your patient, not do the reporting for the radiology department. Try to make a separate department if possible. Always tell them ki I will have my separate department other than the radiology. If you are in the radiology, always make sure कि उनके reporting के उसमें नहीं आना है कि I will do the reporting for 3 hours, 2 hours, 1 hour, because interventional radiology is a branch जहाँ पे fix नहीं है time.
Something like we report all the CT angios, we report all the MR angios, or we report like vascular Dopplers. They are the supervisors for the DMRD, because we know we generate patients from there. But pura we are not sitting and saying I'll report everything.
Because sir,
thank you, sir. Sir,
junior जब जाता है ना सर वो, because that is under the department head, radiology department head, तो उसके लिए मुश्किल है. So directly पहले मना करना is better rather than बाद में किसी को आप ले सकते हो, वो easy होता है.
What you said,
sir, if you could take this next question, sir, about fellowship versus DM. There's a lot of this, probably the most commonly asked question. What is the MCI recognition status? Is there any differences in salaries, work opportunities, and whether it's worth doing the 3-year program as opposed to simply?
So one of the problems I personally feel all the fellowships has to slowly fade away. The reason being that in any hospital that is going to be having an NABH or a teaching institute, since the DM courses and the DRNPs have come, it's a matter of time before all of them will stop allowing you to practice itself. Now, this is a problem that took place even in many centers like Astra Medicity. They said, no, when our fellows were going, they said, you cannot do neuro. You need to have a DM to practice neuro. So these challenges will become more and more as the numbers increase. So it has to be a slow fading out, and every center that is doing a fellowship should apply for DRNB interventional radiology. Because see, once DM cardiology has started, do you think anyone running a fellowship in cardiology will have any a chance to do angios or CATs? He can't. So till that was there, so that phase is over. Now a new phase is starting. So every center that actually offers fellowships should now try to convert them into DRNB seats. Because we'll have a challenge. It's a big problem that will take place. Not only that, it's very unfair for the DM students and the DRNB students. You go and say, I've done 3-year course. This fellow says 1-year course. He says, I will want 4 lakhs salary. This fellow says, I'll do for 2 lakhs. So inside all these are conflicts. And over a matter of time, another 10 years time, you will find that you can't get a job just with a fellowship from any place as the numbers increase. So I think if whoever wants to get into a proper NMC recognized course, no fellowship is recognized by the NMC.
So this is a transition time for us, like cardiology, the neurosurgeons. This is a transition time for us also, the interventional. This is going to take maybe 5 or 7 years. All the centers is going to convert to the super specialization, and after 10 years, I'm going to show I can give any writing also. Nobody after doing a fellowship can get a job in the medical college, especially by the NMC recognized centers, or in the centers where they have some degree, like in Ganga. So we are preferring DM resident, DM candidates rather than the fellows for the job of consultant.
Medical legal violation of this.
Yeah. I have got a small comment regarding this. Can you go to the previous question? See, basically for academic recognition of fellowship in a teaching center, any new course which has started, let's say DM Interventional Radiology has started 5 years ago, there will be relaxation for the faculty for the next 10 years. After 10 years, they will be asking for a formal teaching background for becoming a faculty. Whereas this relaxation will be given for next 10 years. So if somebody asks whether fellowship is adequate to become a teacher, fellowship plus 1 more year, then the person will be eligible to become an assistant professor. So this is what is broadly practiced. Thank you.
So I'll have to leave. It's a bit late. So thank you so much, everyone. Thank you for organizing this, and I hope it has helped someone. Yeah.
Okay. Thanks, Dr. Matthew, for joining.
Bye-bye. Yeah.
Thank you, sir.
Shall we move to the next question?
So one question is from the hello everyone. I would like to know how overcome fear of doing any complication and fear of failure in doing a procedure. Dr. Shyam sir.
Okay, complications are part of the procedure, and we have to take all the precautions. And when complications do happen, we have to audit such cases. And that is one way we can do things within the department. And we have to see what has gone wrong. And at association level, we have every year complication meet, and we encourage members to come and participate and share your experience. And when complications happen, we do feel bad. It is just like a new driver taking a new car. There'll be some adverse effects happening. It is part of our life. And as far as possible, we have to remember the good cases we have done, good results we got, and so that we can come out of emotional upset at that point of time. And if we are doing any procedure today, consenting is very much important so that medico-legally you are protected. However, if things have gone by some miscalculation, it is difficult to face the situation, but over a period of time, we'll become back to normal.
Thank you, sir. Sir, another question regarding Tier 2 and Tier 3 cities, whether it is worth doing a DM program or is a fellowship enough to survive in a Tier 2 city, especially where you don't have big corporate setup cath labs. Anything regarding this, sir?
Okay. I think whatever best training we can get, that is what we can get at that period of time. And when you're getting an opportunity to DM or DNB, that time we don't have to think that I may be going to a Tier 2 city and I can have a lesser exposure. Remember, always 3-year training is better than 2-year training. And I have seen many people who have got 1 year or 2-year training. They have continued working so that they get more confidence in tackling the situation. And that is a general trend what I have seen.
Thank you, sir. Sir, another common question asked abroad opportunities, sir. Post DM or post fellowship, what are the IR consultant posts you can assemble the Middle Eastern countries, sir? If all of you could come to this question.
So, Samarth, for the post DM or post fellowship, there is a difference between especially in Dubai and Middle East, they have their separate the interview, and now they also recognize the DM IR or DRNB program in their whatsoever their the license program. So in their license interview, if someone is DM or DRNB IR, is given preference over the 3 years, as Dr. Shyam is saying. If someone is fellow and having 2 more year experience in the medical college, then they only considered as an IR. And someone is DM, they have preferred the DM over that experienced person as an IR. For the Australia and US, for the US, you have to do a USMLE. There are no other pathways. There are some pathways there where you can get a research entry or something. So that is mostly dependent on your LORs, like letter of recommendations. And letter of recommendation is also good when you are from a good institute. For the post in Australia, it's about you have to clear Ranger or something. There are many smaller centers where they still recognize our degree and fellowship.
but I don't know about the difference between the fellowship and DM in the Australia.
Ajit,
I
sir,
will
if
just
you-
add to it, Samad. Regarding UK, UK has a dearth of IR professionals right now, and so many of my friends and my contemporaries, they have moved to UK. 2-3 of our students, then my contemporary during fellowship in CMC, and it all depends on the opportunities there. So if the opportunities are, if they need more IRs, they will, be a little, they will relax the norms a little. So right now, UK needs IRs in a big number.
Thank you, sir. Sir, another thing, sir, another question that was commonly asked, Ajit sir, if you could take this IR and private practice, how is it different from institutional practice? Sir?
So I think nowadays we have a trend of IR clinics all over the India, and it was started just a pulse clinic in the Nagpur by Dr. Rajesh Mundra and Dr. Atul Revatkar. It was 20 years before, and now we have more than, I think, 50 IR clinics across the India. In Jaipur only, I know 4 or 5 centers, in the Surat, in the Ahmedabad, in the south also. So nowadays the IR is like in a cardiologist or any other physicians who can have their own setup. So you can start your own setup with just an ultrasound machine on 1 or 2 bed. You can start with the practice with varicose vein ablation. You can start with the practice with FNAC or biopsies. You can have an attachment in some nearby hospital to do the cath lab cases, and then slowly, whenever you like earning more, and you can expand your setup. While in relation with this is the private practice. If you want to do job in corporate sector, like in the private sector, like in Gangaram Hospital, Medanta, Apollo, and these private hospitals, so we have the post, like we usually recruit the consultants on every like 2 or 3 years, maybe whenever expansion of department, we always do the openings in these centers, the corporate sectors. That depends on the like how much work you want to do, like which kind of work. Like mostly in Gangaram, we are doing most of the body interventions and the hepatobiliary. In the contrary to that, Dr. Matthew is doing most of the like all of the neuro, aortic, and other things. So if you want to expand your expansion also, and you want to do the work also as a consultant, you have to choose your the institution first, which kind of work you want to do and which kind of work you want to learn as a consultant also. So that is an where you want to settle. Like if you are from Delhi, if you have done consultancy with the Dr. Matthew for 2 years and you want to come back to Delhi, then you can have any other option. Like you can join the smaller hospital as a head of the department, or you can join as a team with the bigger hospital with a team. So that all depends on your how you want to grow in your life.
Thank you, sir. That was another common question which many people had asked, so it's a very relevant thing. So lastly, about radiation risks. This again, everybody's fear about radiation risks in IR. If all of you could again come into this question, what exactly is it a myth or is it has to be followed? Whether it's something to be feared so much, sir, if you could shed some light.
I think this has been covered by 2-3 speakers. I think I personally say that it's very important to protect yourself before you think of protecting others. And it is very important that proper rules are followed and you regularly wear radiation badges and send them for analysis. And as far as possible, try to avoid direct radiation to any body parts. And so these are some suggestions from my side.
So सबसे ज्यादा जो रेडिएशन वर्कर्स हैं उनमें सबसे ज्यादा पढ़े लिखे हम हैं, whether is a orthopedician, whether is a cardiologist, whether is a vascular surgeons. So the most knowledgeable person about the radiation risk and how to prevent them is the radiologist. So if you go into the radiation field, in comparison to your colleagues in ortho, in spine, in cardiology, in vascular surgery, you are the most knowledgeable person as a radiologist. You know about everything about the radiation, about the machine, about the X-ray, about the scattered radiation. So we have an advantage over that. We can save ourselves with the little like more cautions. We know also about the TLDs, readings, and everything. So for this reason, I am telling we are more like say lucky enough to be radiologist first and then we are going to IR. So हम अपने आप को उनसे ज्यादा बेटर बचा सकते हैं। उन लोगों के कंपैरिजन में हम लोगों को ज्यादा पता है, तो रेडिएशन से हमें डर भी ज्यादा लगता है बट प्रोटेक्शन भी हमारी सबसे ज्यादा है।
True, sir. Thank you so much. So I think that covers most of the questions out of the 150 that I narrowed it down to. So thank you everyone who are still listening to us. Close to around 100 people are still online after 3 hours of a session. So I think that goes to show that we have such a motivated young radiology residents in India who are still going after 3 hours of this extensive talk. Thank you again for all of you. Thank you again for all the questions, and thank you to
I
the
think
experts.
Samarth, give them your junior wing email ID as well as our secretary email ID. कोई भी
Surely, sir.
अगर anyone wants to do anything like related question with a fellowship or DM and he wants to come and observe for a IR, we can guide them to the nearest IR center. Whosoever like interested student and the interested mentor, we can connect the mentor to the student. So any of the radiology students, if you want to an IR but you're still not sure which kind of brand it is and how it's going to be like the future, and you want to see the IR first and you want to shadow us or you want to see us first, you are most welcome to any of the center nearby, and definitely junior wing is going to connect it to me, Dr. Sham, Dr. Pushpender, or to the your nearest IR center. So you are all welcome to the IR fraternity anytime for the observership, or if you just want to see for the cases for 1 day or for 1 week or for 1 month, you can come anytime and then you can decide for the whether you want to be an IR or not.
Yes,
Thank you,
Samarth, I
sir.
just want to add,
Sir, yes.
I just want
Yes,
to add one quick thing. The number of seats and the number of opportunities is only going to increase with all the new AIMS being opened, and most of the places in the new AIMS having a trained IR person. We are going to see more of DM courses opening up. Secondly, ISVR is looking at collaborating with centers so that they can convert the fellowships into DRNB. So don't be disheartened that the number is in 2 digits. Very quickly it's going to be in 3 digits, and I'm very thankful to the ISVR UA team as well as all the participants for spending so much time. Just goes to show that how dedicated and motivated they are to pursue IR.
Absolutely, sir. Sham sir, if we could deliver the closing remarks for this, what has been a wonderful 3-hour session, sir.
Okay. I'll keep a very short closing remarks as people have stayed for such a long time. I must thank ISVIR Youth Wing, Samartha Gowda, Avinash, Damadip Singh, Darshan Tomar, Prajit Rai, Shikhar Garg. Have I left out anybody, Dr. Ajit? Okay. I think this Youth Wing is doing a wonderful job. And all speakers, Dr. Matthew, Dr. Ajit, Dr. Pushpinder, and Dr. Jenny, you have shared your pulse of wisdom. And I learned many things by listening to you. And many aspects have been covered. And I have not seen any program done in such a short period of time in covering so many aspects. And our successful candidates who were represented by Damandeep Singh, Sai Charan, Amandeep Singh, Dr. Asim, Dr. Abrar, Dr. Avinash, and Dr. Amrita. I'm individually calling your names because you have spoken from your hearts. It is really, really wonderful how hard work you have done and reached this level. And I'm sure you will be our future. And when we have problems, you are the ones who are going to treat us. So if you're trained well, we are very happy. And on behalf of ISVIR as president and Dr. Ajit Yadav, I thank you all and have a wonderful remaining weekend.
Thank you, sir. Thank you. Thank you, everybody, for this amazing talk. Have a wonderful evening. Thank you, everyone.